Now, welcome to Basic Tactical Casualty Care First Responder Operations. Now, this course is really designed for EMT level responders who may be called to provide basic emergency medical care during an active law enforcement incident. Now, that phrase specifically, active law enforcement incident, that's the key element, right? So it does not mean that EMS personnel suddenly become law enforcement. It means that the medical problem is happening in an environment really where law enforcement operations, responder safety, patient access, and evacuation all affect how care is actually being delivered. Now, in a traditional EMS call, we usually think in a very familiar sequencing, scene safety, patient access, you're assessing the patient, treating the patient, transport, and then transfer care. Now, in a BTCC environment, that sequence still matters, but it may be compressed, right? It could be interrupted or delayed by these threatening conditions. A patient may have severe bleeding, but the area may not yet be fully secured. Now, a casualty may need rapid movement before a complete assessment is actually possible. Multiple agencies may be operating at the same time, really each with a different mission. So, in this course, we're not just learning isolated trauma skills, okay? We're learning how to apply life saving care within a coordinated public safety type response. Now, the California EMSA Tactical First Aid course now is specifically intended to give first responders that basic tactical casualty care techniques and really a broad overview of law enforcement tactical operations and first responder rescue operations. So the key word there is an overview, right? This is not, a SWAT medic type training. This is not tactical medicine for special operations. This is the first responder operations level. The goal really is to prepare you to recognize immediate life threats, apply basic interventions within your scope of practice, support casualty movement, communicate clearly, and really integrate yourself within the EMS system. Now, for this certification, there are two major components. Okay, the first is going to be the lecture portion, where we're just going to build the knowledge base. That's going to include the terminology, operational zones, responder roles, care priorities, hemorrhage control, airway breathing concerns, casualty movement, MCI components, and your missed reporting. Okay. Now, the second part is going to be the lab portion. So this is where you're going to demonstrate that you can really perform the required skills. Now, the lab is not just a practice session, okay? It's really where the knowledge becomes performance. A recurring theme throughout this course is scope, right? Now, as EMT students, you're learning care at the EMT and the first responder operational level. That means your decisions must remain consistent with your certification level. Now, not only that, but also with local EMS agency policy, your specific agency policy, medical director approval, and just the role you were assigned during an incident. Now, national guidelines like the TECC helps explain the principles, but it does not override your local policy. Okay. So, if local policy is more restrictive, local policy is what's going to be in control. Now, by the end of the course, really the expectation is not that you can manage every aspect of a really complex tactical incident. The expectation is just that you can function safely, effectively as an EMT level responder within the BTC FRO framework. Okay, so you should be able to recognize what matters first, perform the basic life saving interventions, move the casualties towards safer care when it's appropriate, and then communicate what you found and what you did, and just understand when a situation just exceeds your role or just your scope. Okay. So, really, as we begin, think of the BTCC FRO as a bridge, right? It connects your EMT trauma training really to the realities of, active violence, terrorism related events, rescue ops, and just a multi agency response. Now, the foundation is still just EMS, patient care, safety, communication, transport to that definitive care. The difference is that the environment may force you to make those decisions faster with really less information and really under tighter operational constraints. Now, the goal. So the goals of this course is pretty straightforward. You're learning how to provide basic, time-sensitive casualty care as an EMT level responder during an incident where the operating environment affects patient access and the overall treatment. Now, the first major goal is going to be to recognize preventable causes of death. So, in trauma, especially in these high threat or just mass casualty environments, we're always asking what can kill this patient soon and what can I actually do about it right now? Now, at the BTC first responder ops level, the most important preventable problem includes your massive external bleeds, airway obstruction, breathing problems just from chest injuries, shock from blood loss, hypothermia and delayed movement to that higher level of care. Now, the second goal is to provide that rapid life saving interventions. Okay. So, this course, again, is not about performing a long head to toe assessment while the patient remains in this really risky location. Okay. It's more about identifying the immediate life threats and applying the intervention that matches that specific threat. So, if the patient is bleeding severely from an extremity, the priority may be direct pressure or a tourniquet, right? If the patient is, unconscious but breathing, the priority may be airway positioning, recovery position. If the patient has an open chest wound, the priority may be, a vented chest seal or an occlusive dressing. So really, the interventions should be simple. They should be fast within your scope, and then of course they need to be reassessed. Okay. Now the third goal is to really work within an assigned response role. Now, in a complex incident, independent action can really create confusion and even danger. So, the basic tactical casualty care first responder operations responder should really not self deploy or make up their own mission. Okay. They operate within the incident structure, they follow local policy, and they complete the task that is assigned to them. So that may mean just staging until you're assigned. Okay. It may mean supporting a rescue task force. It may mean, working as a casualty collection point, maybe assisting with movement, triage, or just transferring care. Okay. The role may change as the incident evolves, but it should always come through the appropriate command structure. Okay. Now, the fourth goal is to move casualties towards that safer care. One of the real major differences between BTCC and just routine trauma care is that movement itself may be life saving. Sometimes the most important intervention is not really staying in place to do more care. It's getting the casualty out of direct or indirect threat area and into a location where more complete care and really transport can occur. Now, that does not mean you're going to move recklessly, right? It means understanding when is rapid extrication appropriate, drags, certain lifts, carries, litter movements. When are those appropriates within the grand plan? Okay. Now, the fifth goal is really to communicate findings using MIST. Okay. In these incidences, information can be lost very quickly. Okay. Casualties move from point of injury to a hallway or to a collection point to a treatment area to an ambulance and then to the hospital. So, if we do not communicate clearly, the next provider may not know really what happened. They may not know where the tourniquet is, what time it was applied, what injuries were found, or just whether the patient deteriorated during the actual movement process. Now, the MIST gives us really a simple structure, okay? Mechanism or that medical complaint, injuries or inspection findings, signs or vital signs, and treatment that was rendered, okay? Now, the final goal here is really to demonstrate competency in the lab. So this is really important because BTCC is really performance based. It's not enough to know that tourniquets exist, right? You must apply one correctly. It's not enough to describe wound packing. You really need to demonstrate the correct concept on some type of trainer. Okay, and it's not enough to know that what MISS stands for. Like what are those four words? You know, you really need to be able to deliver a concise patient handoff under scenario specific conditions. So the lab is where we confirm that you can move from knowledge to action, right? So as we go through this lecture, listen for two kinds of information. First, you want to listen for what you need to know for the written competencies, you know, definitions, principles, priorities, decision making. Second, you want to listen for what you will need to perform in the lab setting. So that's going to be your hands on skills, your reassessment habits, communication steps, and just overall scenario behaviors. Okay. The lecture and the lab are not separate courses, they're two parts of really the same certification process. Now, BTCC FRO really matters because some emergencies do not unfold like that normal EMS call that we're used to. On a routine call, you are trained really to wait until that scene is safe. Enter, assess, treat, and then you transport, right? That is still the foundational EMS principle, but responder safety is still essential, and nothing in this course is going to remove that responsibility. But during an active, violent, terrorism-related incident, or just an active law enforcement incident, the scene may not become completely secure before patients begin to die from treatable injuries. So, this is really the gap that BTCC is designed to address. The California EMSA guidelines were really developed because of active shooter and terrorism incidents require careful coordination between EMS, fire, law enforcement, and just other safety entities, right? The EMSA, they recognize that medical planning and response in these events really cannot be separated from the operational environment. Okay, so the patient's injuries matter, but so do access, threat conditions, the law enforcement activity, the available resources, communications, and the evacuation routes. Okay, a major clinical reason this course exists is really because of severe bleeding. The American College of Surgeons, the Stop the Bleed program, they really identify bleeding as the number one cause of preventable death after injury. So that should really immediately shape how we think as EMTs. If someone is bleeding severely, the window to intervene can be very short. So you may not have time to wait for that perfect scene, a complete assessment, or just a fully developed treatment area before that first life saving action is required. Okay. Now, that does not mean you're just going to rush in blindly into danger. It just means having a system that allows responders to bring life saving care closer to the point of injury when the incident plan actually permits it. Now, we have TECC guidelines that really makes this point really clear. In environments with real or just perceived threats, the traditional response models that prioritize that complete scene safety before any patient care that can create treatment delays, that negatively will affect the patient and the rescuer outcomes. So TECC responds to that problem by emphasizing that immediate access to the injured, rapid life-saving interventions, and really at or near the point of injury, and really early extrication for patients who need to get transport to that definitive care. Now, for EMT students, really the practical meaning here is that time sensitive trauma care really needs to be balanced with operational safety. You're not being asked to ignore safety, okay? You're being trained to understand how patient care may occur in different phases, depending on whether the casualty is in a hot zone, a warm zone, or a cold zone. Now, in that direct threat phase, care may be extremely limited. Okay, in the indirect threat phase, life-saving interventions may be performed while preparing for extrication. Okay, um, In evacuation care, reassessment, documentation, packaging, transport coordination, and that handoff become more complete. Okay, there's research that supports the importance of early hemorrhage control. There's a systematic review of civilian pre-hospital tourniquet use that found, although evidence base was heterogeneous and often low quality, the included studies really consistently suggested that commercial tourniquets used for life threatening extremity hemorrhage were associated with improved survival, reduced need for blood transfusions, and a few mainly transient adverse effects. Okay. Um, that does not mean tourniquets are used what we call like casually, right? It means that when it's indicated and properly applied, tourniquets are a critical intervention. So, really, basic tactical casualty care first responder operations. This matters for three specific reasons. Okay. First, the injury pattern can be time critical. Severe bleeding, airway compromise, chest injuries, shock, all of those can progress quickly. Okay. Secondly, the operating environment can delay that normal EMS access. A patient may need a responder who understands how to function within a specific rescue framework. Now, third, the response needs to be coordinated. Law enforcement, fire, EMS, and other public safety personnel have to share terminology, understand each other's roles, and move casualties through the system just more efficiently. Okay. Really, in simplistic terms, this course is about reducing these preventable deaths by getting the right basic care to the right casualty at the right time, all while keeping responders within their role, within their scope, and within the overall incident plan. Now, the mindset here is different from memorizing a list of skills. Okay, it's really a way of thinking under pressure. Okay. Now, the first part of the mindset is to do the most important intervention first. Now, in trauma care, not every problem has the same urgency. A minor wound can just wait, right? A complete set of vitals can sometimes wait. A detailed history can wait, but that massive bleed, that cannot, okay? An airway obstruction cannot. An open chest wound with breathing compromise cannot. So the responder has to identify what is really most likely to kill the casualty soon and then address that first. Now, really, this is why many tactical casualty care frameworks use a priority sequence like something called MARCH or the XABCDE. Now, the exact acronym may vary by agency, by program, by EMT course, but really the principle is going to be consistent. Extenuating bleeding and other immediate life threats are going to be addressed before more lower priority tasks. Now, in this course, we will keep the sequence kind of simple and EMT appropriate. Okay, massive bleeding, airway, breathing, and chest wounds, and then circulation or shock concerns. We have hypothermia prevention, reassessment, movement, and finally we have that handoff. Now, the second part of this mindset is to match the care to the threat environment. So the same patient may receive different care, really depending on whether they're in a hot zone, warm zone, or cold zone. Now, if they're in a direct threat environment, the best medical decision may be to move the casualty or direct self aid rather than stop for a real detailed assessment. In a warm zone, these life saving interventions may be performed, but the casualty still needs to be prepared for rapid extraction. Okay. Now, in a cold zone, you may have more time and safety to reassess, to document, package, coordinate your transport, and then just communicate a more like complete report. Um, but this is where students sometimes make a critical mistake. They assume that tactical casualty care just means doing more interventions. But in reality, tactical casualty care, that often means doing fewer things, but doing the right things earlier. Okay. It means recognizing that a long treatment sequence is the wrong location. At the wrong location can be dangerous. Okay. It also means understanding that movement is sometimes part of the treatment plan. Getting a casualty from a higher threat area to a safer treatment area can be just as important as the intervention that you're conducting itself. Now, the third part of the mindset is to really treat rapidly and then move towards safety. Okay, that does not mean ignoring care after the first intervention. It just means stabilizing the immediate life threat enough to move the casualty to the next level of care. A good example here is, you're going to apply a tourniquet. You want to verify the bleeding has been controlled, secure the tourniquet, and then move the patient. Okay. You want to seal the chest wound, reassess breathing, and then move the patient. Position the airway, confirm the patient's breathing, and then move the patient. Right. The goal is not to create a perfect treatment environment at the point of injury. The goal is to keep the casualty alive long enough to reach more definitive care. Okay. Now, the fourth part here is to reassess after every intervention and every movement. This is one of the most important habits in the entire course. Tourniquets, they can loosen. Your dressings can shift. Chest seals can fail. A casualty who was talking can be confused, right? A breathing problem can worsen. Hypothermia can develop even in a warm climate because trauma patients lose heat when they're exposed, wet, shocked, or just lying on a cold surface, right? Your reassessment here is not just a simple paperwork task, it's a life-saving behavior. After you move a casualty, check bleeding again. After you apply a tourniquet, check whether the bleeding actually stopped. After you seal that chest wound, watch for any worsening respiratory distress. Okay. Before the transfer of care, you really need to reassess so your missed report really reflects the patient's current condition and not what the patient's condition was 5 minutes ago. Now, the final part here of the mindset is your understanding your role, your scope, command, and communication. In these high stress events, people can feel pressure to really act outside their role. But a good responder stays disciplined, right? They know what they are trained and authorized to do. They operate through command, they communicate clearly, they avoid freelancing, okay? They simply understand that an organized response is going to have a more of an impact to save lives than a disconnected individual heroics. Okay. So as we move through the rest of the course, just keep coming back to the mindset that you want to identify these life threats, do these essential interventions, move towards safety, reassess, and then communicate clearly. Okay. And especially all within your EMT scope and your specific assigned role. Now, here is really what defines what this course is, okay? So that we all have like kind of we're all working with the same expectations, okay? Now, the basic tactical casualty care first responder ops is basic tactical care for EMT level responders, okay? The word basic here it's not unimportant, okay? It means that the course really focuses on the essential interventions that can be performed early, safely, and within a first responders operational role. Okay, in many trauma situations, the basic intervention is the life-saving intervention: direct pressure, tourniquet, wound packing, airway positioning, putting the patient in the recovery position, applying a chest seal, preventing hypothermia, moving the patient, having a clear handoff to more definitive care. That can make all the difference in the world. So this course is trying to teach you that the medical care in these rescues and in these high threat contexts, okay, that the phrase needs to be understood carefully. We're not training you to conduct tactical operations. We're just training you to understand how medical care may be delivered when rescue operations, law enforcement activity, and scene conditions can affect your patient access. Okay. You're going to hear all about hot zones, warm zones, cold zones, rescue task force, casualty collection points, um, concealment, cover, command, ingress, egress, staging. So those concepts matter here because they shape where and how patient care can actually occur. We're also going to teach you about zone based decision making, or at least as it refers to patient care. And now, because in routine EMS, we often think of patient care as just one continuous process, right? But in tactical casualty care, we're gonna divide it into phases because the threat environment changes what is safe, what is realistic, and really what should be prioritized. In the hot zone, the priority may be movement and very limited hemorrhage control. In the warm zone, you may perform life saving interventions while preparing for extraction. But in the cold zone, you may reassess, package, document, coordinate your transport, and give a more organized handoff. Okay. But now, the clinical content in this course is going to center around the problems that are most likely going to kill early and the interventions appropriate for an EMT level BTCC responder. So, we're going to spend a significant time on bleeding control, but again, that's because massive hemorrhage is one of the most time sensitive and preventable causes of death. We're also going to cover some basic airway management, breathing, chest injuries, recognition of shock, hypothermia prevention, casualty movement, and again, your whole reporting through MIST. Okay. MIST is going to be included because patient care does not end when you simply apply a tourniquet or move someone to the CCP. The next provider needs to know what happened, what injuries were found, what signs were observed, what treatment was conducted. Okay. In a mass multi-casualty incident, a concise structured report is really going to prevent information from being lost. Okay. So really this course just helps prepare you for both the written and the skills competency. The really the written portion is going to evaluate whether you understand the concepts, and again we're talking about the terminology, different roles, the zones, priorities, scope, reporting, where the lab is going to really evaluate whether you can perform the required skills like bleeding control, airway positioning, chest injury care, casualty movement, your missed reporting. And we're going to talk more about this in the lab session. Now, in uh, in different words, really, this course again is not complete until the knowledge is connected to your performance. Um, the BTCC FRO is not meant to replace your EMT curriculum. It's going to build on it. Okay, your EMT training gives you the foundation of patient assessment, trauma care, airway management, bleeding control, shock recognition, transport decision making. The BTCC adds the operational layer. Okay, how those priorities are adapted when threat, rescue, command, and evacuation shape your timeline. So really, throughout the course, just keep on asking yourself, what is the immediate life threat, right? What can I do within my scope of practice? What zone am I currently in? What does command need? Where is the casualty going next? What does the next provider need to know? Okay, that is going to be the practical center of your BTCC FRO curriculum and knowledge. So, before we really go in any further, okay, we went over what it is, but now we really need to be clear about what this course is not. Okay, BTCC FRO is not SWAT medic training. Okay, it's not tactical medicine for special ops. It's not a law enforcement tactics course. Okay, it does not teach you how to clear a room, firearms handling, weapon use, assault tactics, threat neutralization. Right now, some students ask quite often, then why are we actually talking about tactical terminology at all? Right. And that's really a fair question. But the answer is that just EMTs and first responders, may need to understand the language of the incident so they can operate safely within their specific medical role. Right. A good example is this: if someone says warm zone, rescue task force, casualty collection point, protected route, egress, you need to understand what that actually means. But understanding terminology is not the same as being trained or authorized to perform tactical law enforcement functions. Okay. California EMSA separates these concepts pretty clearly. You have tactical first aid is just the basic first responder ops level course. Okay, it provides specialized tactical medical care techniques and a brief overview of tactical response and operational methodologies. Okay. Now, by contrast, a tactical medicine for special ops, this is a separate pathway that's really associated with personnel that's integrating into a SWAT type operation. Okay. Now, those personnel may operate in areas with a direct and like immediate safety threat, and they require a different level of training, operational assignment, medical oversight, and just overall agency authorization. All right. So, really as an EMT student in this course, your role is not to become part of a contact team. Your role is not to really search for a threat. You're not going to clear rooms or make any type of law enforcement tactical decision. Your role again is to understand how medical care, rescue movement, and communication may occur during an active law enforcement incident, specifically when you're assigned a medical or rescue support function. Now, that specific distinction is going to be imperative because these incidents are already so complex. If a medical responder just begins to freelance outside of their role, they can create that additional risk. They can confuse the incident command structure, and worst of all, it's going to result in a delay of care for patients that they're trying to help. Okay, so in this tactical casualty care, discipline is a safety intervention. Staying in your lane is not a passive thing. It's part of a coordinated emergency response. But this also means that the BTCC FRO does not authorize you to exceed your EMT scope of practice. If a skill is not within your certification level, not approved by your local EMS agency, or just not authorized by your medical director, or it's not part of your assigned incident role, then this course does not make that skill permissible. Okay. So you're going to learn about tourniquets. You're going to learn about direct pressure, hemostatic dressings, wound packing, pressure dressings, basic airway positioning, chest seals, recovery position, putting a patient in position of comfort, casualty movement, CCP operations, misreporting, scenario based decision making, all of which should be kind of a refresher, but we're still going to go a little bit deeper into it. But again, those are the medical and rescue support priorities for this specific course. So really, the boundary here is just that BTCC FRO teaches medical care in that tactical rescue environment. Okay, but it does not teach the actual tactics. So now that we kind of have a good definition and hard to find lines of the limits of this course, really let's talk about the BTCC FRO certification and what it focuses on. Okay. The certification again is not just attendance. It's not simply being exposed to the lecture and the slides. It's not only watching me or one of your instructors demonstrate the different techniques for skills. Certification means you can show that you understand the required concepts and can perform the required skills at the level expected of a BTCC Pro responder. Okay. Now, the first certification focuses going to be terminology. You need to know words like the hot zone, warm zone, cold zone, casualty collection point. You're going to need to know rescue task force, covering concealment, contact team, rescue team, staging, ingress, egress, and mist. Okay, all of which we're going to cover. But again, these are not just vocabulary words for your exam. They are the common language that just allows multiple agencies to work together during these really high stress events. Okay, the second focus really be integration. BTCC FRO responders do not work in isolation. Law enforcement, fire, EMS, dispatch, hospitals. They partner together because they can all be involved at the same time. So you need to understand really the basic roles of each discipline. Law enforcement focuses on really the threat mitigation. Fire EMS focus on triage, treatment, movement, transport. The unified command and the ICS help those specific priorities stay organized instead of competing with each other. The third focus is going to be your zone based care. This is going to be one of the central ideas of the tactical casualty care. The care you provide really depends on the threat environment. So, in a hot zone or direct threat environment, the safest and most appropriate action, again, may be movement, self aid, or just very limited bleeding control, right? In a warm zone or that indirect threat environment, the life-saving interventions can be performed more, easily, accessibly, but they must be rapid and tied to the extraction. In a cold zone or evacuation care environment, reassessment, document, package, transport, and then the handoff becomes more complete. Okay. Now, the fourth focus again is going to be your skill performance. Once again, you need to demonstrate the required life saving skills in the lab. That's going to be your direct pressure tourniquet, tourniquet application, but also the tourniquet application on yourself. Okay. So that's something that it's going to be something new. Um, Wound packing with an approved hemostatic dressing, which we're going to cover that later on in the lecture. Pressure dressings, airway positioning, recovery position, putting a patient in a position of comfort, how to do a chest seal or occlusive dressing, how to do appropriate casualty movements, and then again your reporting. Now, the fifth focus is your communication. In a complex incident, the patient information can disappear very quickly. So a casualty may move from point of injury to a hallway, to that CCP area we were talking about, to a transport area, to the ambulance, and then to the final definitive care at the hospital. So if you do not give a clear report, that next provider may not know the mechanism of injury, the injuries that occurred, the vital signs, the mental status, if a tourniquet was applied and where, when was it applied, how did the patient actually respond to the treatment. So that's really why the missed reporting becomes part of the competency, not just that documentation component. The sixth focus is going to be that integrated scenario performance. So, in real life, skills do not happen in that clean checklist order, right? You may have to decide whether to move first or treat first. You may need to apply a tourniquet while another responder prepares to drag the patient. You may need to reassess a chest seal after you move the patient. You may need to give a mist while multiple casualties are being triaged. So the scenario portion is going to be designed to bring all those little pieces together. Okay. So when preparing for certification, you need to think in like three separate layers. Know it, you need to do it, and then you need to apply it. So know the terms and the principles, do the hands-on skills correctly, and then apply both under a realistic EMT FRO level type scenario while also staying within your scope of practice. So this slide is one of the more, again, it's going to be one of the more important slides on safety. Okay. So again, the rule here is simple. We've talked about it. You need to perform only approved skills within your certification level. Make sure it's under your local policy, your medical direction, your agency training, and your assigned incident role. So, again, this whole thing is going to sound very repetitive, but each part really matters in this course. First, you must stay within your certification level. So, as EMT students, you're learning BTCC FRO at the EMT and first responder ops level. Okay, that means the interventions or that we're going to emphasize are just basic life saving interventions. We're talking bleeding control. Again, we're talking airway positioning, recovery position, sealing up a sucking chest wound, making sure the patient doesn't go into hypothermia, how to appropriately safely move a patient, and then how do you reassess, and then how do you document. So again, this course does not all of a sudden turn an EMT student into an advanced EMT or into a medic or into a tactical medic or a nurse or a PA or a physician or just some type of SWAT integrated medical provider. Okay. Um, Secondly, the local EMS agency policy is very important. California EMSA provides that statewide training guidance, but your local EMS agency determines how those principles are applied within your specific jurisdiction. EMSA explicitly notes that responders need to stay within their scope of practice for their certification or licensure level and follow the protocols approved by your local EMS agency. So even if you read about a skill in your TECC, TCCC, a textbook, another agency's policy, that does not automatically authorize you to perform it, okay? Especially here. The third is just your medical director approval is also very important. Your tactical casualty care is still medical care. So the fact that this scene is unusual does not remove medical oversight. So if a medication, device, airway adjunct, hemostatic product, triage method, chest seal procedure, um, patient movement procedure, that requires approval, and that approval must exist before the responder uses it in the field. Fourth, the agency policy and training is very important. A skill is not only about whether it is legally possible, right? It's also about whether your agency has trained you, has equipped you with the appropriate tools, and assigned you specifically to perform it. So, think about like a responder may conceptually understand being part of a rescue task operation, but that doesn't mean they are authorized to enter a warm zone. Okay. Warm zone entry depends on local policy, your command assignment, law enforcement protection, PPE, communication, and then, of course, the operational plan. Now, next, you're assigned incident role specific. Scope is not only a list of the medical skills; it also includes what you were assigned to do at that specific incident. You might be staged. You might be assigned to a CCP. You may be part of a treatment group. Maybe you're supporting casualty movement. Maybe you're just assigned to communicate missed reports, right? So you should not leave that specific assignment because you see another task that looks more urgent or just more fun. So if priorities change, command should redirect those resources. So you need to wait. A helpful way to think about this. Training tells you really what you've learned. The scope tells you what you're allowed to do. And the assignment tells you what you're supposed to do right now. See, all three of those have to align together, right? This whole concept also protects the patient, right? So, in high stress situations, patients do not need those random interventions. They need the right intervention performed correctly by the right responder at the right time with the next provider informed. Okay. So scope discipline keeps that patient care organized and just defensible. Okay. So throughout the rest of this course, whether whenever we introduce a skill, you just have to ask yourself: Is this within my EMT level BTCC FRO? Is it locally approved? Is it supported by my agency's training and the equipment? Is it appropriate for the zone? And simply, am I assigned to do that specific task? So here we're gonna again continue to build on the scope of practice. Okay, so in BTCC FRO, local policy again is always going to control everything. So again, not just a legal statement; it's an operational kind of reality for you. Active law enforcement incidences. They're managed locally because each jurisdiction has different geography, staffing, resources, whether it's law enforcement, fire, medical, hospital access. They have different communication systems and training. So that means two EMTs that are trained in the same like general BTCC principles may function differently in two different jurisdictions. Really, one agency may have that formal, rescue task force model. Another may use a different protected rescue model. One agency may, authorize certain personnel to operate in a warm zone under specific conditions. Another may restrict EMS personnel to only cold zones or CCP operations. One agency may, issue you ballistic PPE like a bulletproof vest, but another may not. So one agency um, may use a triage system that's different from yours. So during this course, we when we discuss concepts like an active shooter response, RTF, warm zone care, PPE, communications, MCI, trauma destinations, the key phrase is always going to be you need to follow your local policy. Okay. So for active shooter response procedures, local policies should define how law enforcement, how fire, EMS, and just other responders are integrated. Okay. It should really clarify uh, who establishes command, who identifies the zones, who authorizes movement, where staging, how resources are requested, and how casualties are moved to treatment and transport. For the rescue task force, local policy again should define who can participate, what training is needed, what PPE is required, how the team is formed, who leads it, what medical equipment is carried, what communications are used, and really what conditions have to exist before the team enters or re enters a warm zone. Now, for these warm zones, specifically when we're talking about the entry criteria, your local policy really needs to be very specific. Okay. So warm zone operations are they shouldn't be based on individual confidence. They require command assignment, coordination with that law enforcement entity, situational awareness, identified routes, emergency egresses, communication, proper personal protective equipment, and really at the undertone is a medical objective. Okay. Your PPE and identification, responders need to know what they are expected to wear and how they should be identified. California EMSA, their quick reference guide just emphasizes PPEs like a ballistic vest and a helmet when it's applicable, as well as clear identification of rescue personnel. But whether that applies to a specific EMT student or an agency is going to depend largely on local policy and what equipment you were issued. Okay. Now, for communication, local policies should really identify the specific radio channels or talk groups, common terminology, duress codes, reporting expectations, and just who communicates with command, the medical group, transport, and receiving facilities. Because overall, poor communications can really turn a manageable rescue op into just pure confusion and chaos very quickly. For these big mass casualty or multi casualty incidents where triage and transport is imperative, your local policy is going to determine the triage method, the casualty tracking system, transportation coordination, destination decisions. Your BTCC FRO students need to understand the START, jumpstart, SALT, and just other local triage concepts, but they must apply the method that's appropriate for your jurisdiction. Now, the more important point is this, national guidance can really help explain principles, but your local policy determines practice. Okay. Um, the CTECC says that these TECC principles are universal, right? But their application is agency, provider, practitioner, resource specific. And now that matches what California MSA approach is. We learn the concepts, but we apply them through that local policy. So whenever you're unsure, just do not ask, what did I see in another course? You really need to ask, what does my local policy, agency procedure, medical direction, and assigned role require me really to do at this particular time? Now, here we're really separating two terms that are really often confused or in the BTCC realm: tactical casualty care and tactical medicine. Now, in California MSA framework, tactical casualty care, again, we call it TCC. This refers to specialized emergency medical care that's delivered by responders from established EMS systems during active shooter or just terrorism related incidences. Okay. Now that includes, public safety personnel, EMTs, AEMTs, paramedics, just depending on the course level, the scope, your agency's role, and local authorization. Now, at the FRO level, TCC is basic and operations focused. Okay. BTCC FRO prepares responders to understand the incident environment, recognize major life threats, perform basic life saving intervention, support casualty movement, and communicate through the EMS system. Okay. It's really designed for responders who may provide medical support in areas where there's really minimal to no direct or immediate safety threat, or just where the threat has been reduced enough that rescue ops may occur under just local policy. Now, that does not mean the environment is just risk free. It means that the responder's medical role is structured through the established EMS system, again, local EMS agency oversight, and just law enforcement coordination, and of course, the command assignment. Now, tactical medicine, specific for special operations, this is going to be different. Okay. Now, EMSA describes tactical medicine for special ops as care delivered by law enforcement personnel that's assigned to a SWAT operations team. Okay. Now, those responders are integrated into the SWAT team, and they're going to provide care in areas where direct and immediate safety threats exist. Okay. Now that is different. That's a different operational role and a different training pathway altogether. And it really is a different authorization structure. Okay, so this distinction is important because the word tactical is what creates that confusion. A student's going to hear tactical and they're going to assume tactical casualty care and assume it means that the same thing as being a tactical medic. Okay, it does not, right? BTCC FRO does not make you a tactical medic. It does not make you a TEMS technician. It does not qualify you for SWAT integration. It does not authorize you to enter direct threat environments independently. Okay, the EMSA training model just shows this clearly. Tactical first aid is the foundational tactical casualty care course. Tactical lifesaver, or TEMS technician is a separate, longer course. Tactical medicine for special ops is its own program area under a EMSA approved pathway. So even when there is overlap in like medical concepts, the roles are not interchangeable. For the EMT student, just the practical takeaway here: your BTCC FRO, your BTC FRO is to provide medical care as part of an EMS system response, right? Within your training and scope, and really under your local operational control. You are learning how to support rescue and casualty care during these active law enforcement incidences, not how to become part of that special ops team. Okay. Now, again, that difference really should guide your decisions throughout the entire course. So, when we discuss these hot zones, warm zones, rescue task force, or tactical operations, we're going to be discussing them so you can understand where the medical component and medical care fits, right? We're not expanding your tactical authority. So, really, the simplest way to say it is that, tactical casualty care is the EMS system's medical response framework. Tactical medicine is a specialized SWAT integrated role. Okay. BTCC FRO belongs to that first. So moving on, here are several terms. Again, you should be somewhat familiar with the first portion of this lecture, but they're often used together. But again, they don't mean the exact same thing. Okay. So let's start with TCC. C. This is Tactical Combat Casualty Care. Now, this is the military combat casualty care framework. It was developed for combat environments where the mission, hazards, evacuation timelines, resources, and responder roles really may be much different from civilian EMS. Okay. Many of the life saving ideas we use today, especially early tourniquet use and stage care under threat, were really strongly influenced by military experience. So TCCC is important background, right? But for this course, it's not the controlling field authority, right? That point is important because a military guideline does not automatically authorize a civilian EMT student or even just an EMT provider to perform a skill in Los Angeles County or anywhere else. The military TCCC may help us understand why hemorrhage control is emphasized, why care is phased, and why movement matters, but it does not replace your California EMSA guidance. Okay. It doesn't replace your EMS policy, your medical direction, or your scope of practice. Next, we have the TECC, which is the Tactical Emergency Casualty Care. TECC is a civilian high threat casualty care framework. It takes lessons from the TCCC and adapts them for civilian rescue and public safety environments. The TECC is especially useful because it recognizes that civilian incidences may involve, active violence, hazardous materials, fires, structural instability, explosions, or just other operational type threats that shape the medical response. The current TECC guidance really describes three dynamic phases of care. You have that direct threat, indirect threat, and evacuation. So those phases are important because they are based on the threat level at that specific moment, not simply a physical location. Okay. So in other words, you look at a hallway, parking lot, classroom, a street. They're not automatically one zone forever, right? The status can change as that threat changes, as law enforcement gains control, as that command updates the routes, or there's new hazards that appear. The TECC is also clear that the principles are not a one size kind of fits all protocol. Care depends on the responder's training, the available equipment, local medical protocols, medical director approval, and just the resources that are actually available at the incident. But really, that's exactly the same approach we're taking here in this class, right? TECC supports our understanding, but the local policy is going to control the application. So now we have the BTCC, which we've been talking about, the Basic Tactical Casualty Care. In California, BTCC comes from the State Tactical Casualty Care Training Framework. It's really designed to prepare public safety personnel and EMS personnel just to provide basic emergency medical care during these active law enforcement incidences like an active shooter and a terrorism related event. Okay. The California EMSA guideline just identifies this course level as tactical first aid or TEMS first responder ops. Okay. Now, that brings us to our last term, and that's going to be the TEMS first responder ops. So, again, FRO is going to be a common term, and that means first responder operations. So, this is the level you are completing, right? It's the basic operational level course. It teaches you terminology, again, the role awareness, zone based medical priorities, the basic casualty care skills, movement and evacuation concepts, medical planning, and then threat assessment coupled with competency based performances. So, a simple way to try to remember the terms is TCCC is military, TECC is civilian high threat guidance, and then BTCC is the California Basic Tactical Casualty Care Training, and then TEMS FRO is the first responder operational level of that specific framework. And then, okay, the final rule is that it is one of the most important for practice, at least, is that again, local EMS policy controls your field application. Okay, if national TECC or the military TCCC differ from local EMS policy, the local policy wins. Okay, if a skill is outside of your EMT scope, is not approved locally or not authorized by your specific agency, this course does not make that acceptable. Okay. For certification, you do not need to become an expert in every national guideline. You don't need to understand the difference between these different frameworks because really they explain why the basic casualty care FRO is structured the way it is, right? Phased care, rapid life saving interventions, early movement towards that safer care, and again, just disciplined practice within your scope of practice. So here we're moving on to why does this course exist, right? And this course exists because active violence and terrorism type incidences create a very different operating environment than those routine EMS calls that we're used to. California's Tactical Casualty Care guidelines really specifically connect your training to active law enforcement incidences, including these active shooters, terrorism events. Okay. The guidelines just help explain that for this training framework, a terrorism incident includes an active shooter incident. Okay. An active shooter incident is described as an incident where an individual is actively engaged in killing or at least attempting to kill people. Okay. Now, that definition is really difficult to hear, but it gives us the operational context, right? These are incidences where the medical problem and the threat problem are happening at the same time. Really, one of the major lessons identified in the California guidelines is that these events may occur in any community, in any place. Okay. They're not limited to just large cities, they're not limited to specific building types, schools, businesses, public venues, transportation areas, houses of worship, government buildings, outdoor gatherings, private facilities may all become incident locations. So for EMT students, the lesson here is that BTCC is not theoretical. It's really a preparedness skill set for these low frequency, high consequence events. Okay. Another important feature is that casualties may be inaccessible at first, right? In a routine EMS call, patient access may be limited by traffic, a locked door, bystanders, maybe an environmental hazard. But in an active law environment, an enforcement incident, patient access may also be limited by an ongoing threat, law enforcement ops, unclear scene boundaries, blocked routes, or the need to wait just for protected movement. So, a casualty may need that immediate bleeding control, but the responders may not be able to reach that casualty safely really until law enforcement and command have established a plan. So, this is why multiple agencies really must respond together. Law enforcement, fire, EMS, dispatch, hospitals, emergency management, sometimes even school officials, private security, public works, they may all have a specific role. These agencies may arrive at random times with different priorities and with different terminology. So, without a common structure, the scene can become disorganized. So, resources may be limited, may be delayed. A major incident can really overwhelm a normal response capacity. Okay. There may not be enough ambulances immediately available. There may not be enough medical personnel at the point of injury. Radio channels can be congested, access points blocked. A single patient care decision really may depend on law enforcement protection, fire rescue capabilities, EMS transport resources. And all of these things are happening all at once. Okay. It's very chaotic. It can be very confusing, and it could always lead to a delay in care. But really, that's why the BTCC emphasizes coordination, right? The goal is not to teach individual responders to act independently. The goal is to prepare responders to operate within that coordinated rescue and medical system. Okay, that includes understanding your zones, communicating through ICS and that unified command, using that common terminology, forming and supporting the RTFs, establishing the CCPs, and just moving casualties towards treatment and transport. So, from a medical perspective, really these incidences are they create a timing problem, right? Serious bleeding, airway obstruction, chest injuries, shock can all progress faster than a large scene can be fully secured. Okay. BTCC and TECC both respond to that reality really by emphasizing that rapid life saving intervention and that early extraction when conditions and just your overall policy allows it. So, when I say when conditions and policy allows it, we're not abandoning scene safety, right? We're really leaning or learning how an organized rescue op can reduce delays without creating any unnecessary additional casualties. So when you hear, active violence and terrorism context, do not think only about the threat. Think about the whole response problem. Think about patient access, the responder safety, your communications, what's the command, how do you move the casualty, and transfer into the EMS and trauma system. So it's just important to understand in these active violence and terrorism related incidences, medical care is never isolated from operations. The patient survival may depend on how well law enforcement, how well fire, EMS, and these public safety responders are able to coordinate under their specific local policy. Now, let's go ahead and shift really from the incident context to the medical reason that BTCC FRO exists, right? And that's the whole point is to prevent death from problems that can be treated early. Now, in trauma care, not every injury is immediately survivable, right? And not every injury can be corrected in the field. But some causes of death are potentially preventable if responders are able to act quickly, use the right intervention, and really move the patient towards that definitive care. BTCC FRO focuses on those early high yield priorities, right? The first priority is always massive external bleeding, right? This is one of the clearest and most time sensitive preventable causes of death. And again, as we talked about earlier, um, identifying bleeding or bleeding is identified as one of the or not is the most preventable death after injury, right? So for EMT students, that statement again should immediately shape your first look at a trauma patient. Before you spend time on lower priority tasks, you really need to ask yourself: is the patient bleeding to death? Right? Massive bleeding may appear as spurting, bright red blood, large pooling of blood, clothing that is rapidly being saturated in blood, um, a traumatic amputation, or just blood loss that's hidden under clothing, right? So the important point is that you don't wait for the patient to become profoundly hypotensive before you actually act. In tactical casualty care environments, if life threatening external bleeding is present and it's feasible for you to intervene, a tourniquet and direct pressure may be the intervention that actually keeps the patient alive long enough for them to actually reach the transport. Now, secondly, the second major priority is going to be your airway, right? You're looking for airway obstruction. So the patient who cannot move air, they cannot survive. Okay, so at this level, airway care is going to be basic, but again, it's always critical. Manual airway positioning with either the head tilt chin lift or the jaw thrust. If there's a suspicion of head or spine injury, put the patient in recovery position or a position of comfort. Now, if the local policy of yours and scope allows it, you want to put an airway adjunct in, like an oropharyngeal airway or a nasopharyngeal airway, just to maintain that open airway. The third priority is going to be breathing compromise. Okay, specifically, we're trying to think since we're dealing with trauma, we're thinking breathing compromise from an actual chest injury. So, a penetrating chest or injury or to the torso that can interfere with your normal breathing. So, as a first responder for BTCC, students really need to be able to recognize open and sucking chest wounds. Okay, they need to be able to apply a vented chest seal when it's available, when it's appropriate, or consider using an occlusive dressing if, again, your local policy allows. You want to check for those exit wounds and then continuously reassess their breathing. Because really, the EMT and the first responder ops role is recognition. Okay, it's basic management, it's reassessment, rapid evacuation, and then reporting. It's not these advanced procedures that are beyond your scope of practice. Now, the next priority is going to be hemorrhagic shock. Okay, and we're just talking about shock in general. Now, shock is not just a blood pressure number. It's a state of hypoperfusion. Okay. Now, in the field, especially early in trauma, you may recognize shock through the patient's mental status, maybe their weak or absent radial pulses, maybe their skin signs, they're pale, cool, diaphoretic, or clammy. Maybe they have a rapid pulse. Maybe there's an actual mechanism of major blood loss. Because hemorrhagic shock just means that the body is really failing to circulate enough oxygen carrying blood to your vital organs. The correction really begins with bleeding control and then rapid movement towards definitive care. Then your fifth priority is going to be your hypothermia after trauma. Now, hypothermia is not only like a wilderness type problem, and it's not only a winter problem. Okay, the trauma patient actually loses a lot of heat when they're exposed, when they're wet, when they're actually in shock, when they're lying on cold surfaces, or just left uncovered during assessment and movement. Hypothermia worsens that trauma physiology and can really contribute to rapid deterioration. EMSA's guide here specifically includes hypothermia prevention by minimizing exposure, replacing their wet clothes if it's possible, insulate the actual casualty, cover the torso, and then just use blankets or just some other type of heat retention type method. Then lastly, we have our final priority, which is delayed movement to definitive care. Now, in BTCC, movement is not, again, just an afterthought. A patient may need a tourniquet, chest seal, airway positioning, and then movement. Okay. Delaying extraction for non life saving tasks can actually be more detrimental to the patient. So, the goal is not to complete every possible field treatment. The goal is to provide life saving care, reassess, and then move the casualty towards a safer treatment area, a transport resource, and then finally to definitive care. Okay. So, again, this should be more of a mental checklist for why we do what we do, right? Bleeding, airway, breathing, shock, hypothermia, movement. So, if you can recognize these problems early and then act within your scope, you're practicing really the core of basic tactical casualty care first responder operations. So let's kind of look. We're going to look more at the medical framework of the course, right? And it's going to be more in a practical sequence. Again, very redundant. We're hitting on this multiple times because that's the whole point of this class, right? So our first priority again is always stop life-threatening bleed. Okay, we have our XABCDs. So in a high threat or a rescue environment, bleeding control may be really the first and most important intervention. If bleeding is from an extremity and it's severe, then a tourniquet may be required. If bleeding is, compressible and not appropriate for a limb tourniquet, direct pressure or wound packing, then a pressure dressing may be applied, right? So the key is not just applying a device, right? The key is to verify that the bleeding has actually stopped. Okay. Your second priority again is going to be to open and maintain that patient's airway. At this level, this is going to be done by either a head tilt chin lift or a jaw thrust maneuver. So it's about positioning. So if the patient is unconscious and breathing, the recovery position can actually help protect that airway and allow any type of fluids to drain out the mouth. If the patient has that airway compromise, this is where that head tilt chin lift, jaw thrust may be more appropriate, really depending on your concerns for trauma and your training. Now, if the patient is conscious and breathing with difficulty, then the position of comfort actually may be best. And you just have to ask them what position they want to be in. But again, airway management is not just about applying a device. It's more about positioning, observing, and just reassessing. Okay. Now your third priority is going to be a is to seal any open chest wounds. Okay, an open or a sucking chest wound can really interfere with breathing and can contribute to a really developing tension pneumothorax. So at this level, the students really need to recognize the problem. expose and inspect when it's feasible, and then just apply a vented chest seal, or again, if your protocol allows it, an occlusive dressing taped on 3 sides or taped on 4 sides, again, depending on the circumstance. And it's also important to always look for that exit wound because, again, you might need to actually cover that hole as well. And then again, reassess the patient's breathing and make treatment decisions based on that reassessment. Um, because, again, one of the most important things is that if a chest seal is not uh, if it's not in the appropriate place, or if it comes loose, you might need to apply it again, or again, just cover the whole thing. Now, our next priority is preventing hypothermia. Okay. Now, this again is linked hypothermia and then shock. So these are linked to patient survival. Shock can be a result of blood loss, especially when the hemorrhage is not controlled early. Hypothermia can worsen trauma, again, physiology, and may occur even in really mild environments. For your position, shock, again, shock management means controlling bleeding, recognizing signs of poor perfusion, prioritizing evacuation, and then keeping the casualty warm while communicating the deterioration to the next provider. Okay. The fifth priority is going to be, again, moving your casualty to safer care. This is, again, the central BTCC concept. In routine EMS, we may prefer to like stabilize before moving, but in tactical casualty care, the environment may require us to really stabilize only the immediate life threat and then move on. Okay. So movement may be from a hot zone to a warm zone, from a warm zone to a CCP, from a CCP to a cold treatment area, or from a treatment area to transport. So each move should be purposeful. It really needs to be communicated and then followed by a reassessment. Our sixth priority is going to be, again, to communicate clearly during the transfer. Treatment without communication is just incomplete care, right? If you apply a tourniquet but fail to report the time and location, the next provider may lose critical information, right? So if you have a seal on a chest wound but do not report worsening breathing, the receiving crew may not understand the specific concern. If you move a casualty and do not update condition changes, the handoff just becomes unreliable. And that's where that missed part is so imperative to this course. That missed gives us a consistent handoff structure, right? What's the medical complaint? What inspection findings did you find? What were the patient's vital signs? And what treatment was actually rendered? So you're going to repeatedly use this in lab because it's really one of the ways we connect the field intervention to that ongoing continuity of care. So the clinical overall clinical flow is going to be simple enough to remember, but it's really important to practice, right? Stop the bleeding, manage the airway, support breathing, prevent shock and heat loss, move towards safer care, and then finally communicate what actually happened. So let's kind of look at the different responder roles, right? So let's look at those roles. We can start with law enforcement. So in an active law enforcement incident, the primary law enforcement role is just to really mitigate the immediate threat, right? So that could involve locating, containing, stopping, and just controlling the threat according to their law enforcement training and their policy. Now, for you as an EMT student, the important point, again, is not the tactical method. The important point is that the threat mitigation is a law enforcement responsibility, not an EMT responsibility. So, this is where the role clarity is very important. In these high stress incidences, everyone wants to help. But again, helping does not mean doing someone else's job. If a medical responders attempt to perform law enforcement functions, they can place themselves really in danger. They can interfere with that threat mitigation, and they just create additional casualties. So our program here just teaches medical integration, not simple tactical decision making. Law enforcement also may provide scene intelligence when it's possible. This scene intelligence really can include information about the suspected threat location, known casualty locations, what are safe routes of ingress and egress, unsafe areas, what weapon concerns there are, access points, evacuation paths, and just has there been any area that has been searched or cleared? And this is all important to understand law enforcement terminology, right? This information just helps command and medical responders decide, where staging is, RTF movement, CCP placement, and just casualty extraction. Where can it occur? Now, law enforcement also helps identify and communicate where the operational zones are. You have the hot zone, warm zone, and the cold zone, right? This terminology is used in this course because it's important to understand medical rescue terminology and how it's tied to threat conditions. But again, medical responders should not independently decide that an area is safe enough for you to enter. The law enforcement coordination coupled with the coordination with command, that provides the threat information that helps establish whether an area is actually a direct threat area, whether it's an indirect threat area or an evacuation care area. Another law enforcement role may be to support protected routes. So, if a rescue task force or rescue team is assigned to access casualties in a warm zone, law enforcement personnel may provide protection and direction for movement. So, again, this occurs only under local policy and command assignment, right? So, it's not something an EMT team actually decides independently. Um, it's also important to note contact and rescue functions, right? So the contact team is a law enforcement concept focused on just addressing the team. In many models, a contact team may move towards the threat, even if casualties are there. So that can be emotionally difficult to understand from a medical perspective. But really, the logic is that stopping the threat prevents more casualties, right? The rescue function is very different as well. Rescue teams or that rescue task force, they focus on reaching, treating, and then moving casualties once the condition actually allows for it to happen. Throughout this course, the contact team and the rescue team concepts, they're going to be included for terminology and just integration, right? We're not teaching how contact teams actually move, how law enforcement searches, or just how tactical decisions are made. Um, but the medical takeaway here is that law enforcement retains authority over law enforcement tactical decisions, while EMS and fire provide the life saving care, the movement support, triage, and transport coordination. So at the EMT level, BTCC provider responder, your relationship with law enforcement is collaborative, right? But they're not interchangeable, right? You need their threat information and protection to safely access patients in these certain conditions. They need medical responders to treat and move those casualties once rescue ops are possible. Okay. Now, the best outcomes occur when each discipline understand its own role and respects the roles of others. Now, the fire and EMS, their role, they really operate in the BTCC FRO as the primary rescue medical component of the entire response, right? So, in an active law enforcement incident, law enforcement is going to be responsible for that actual threat mitigation, like we talked about. But now, fire and EMS, they're going to be responsible for really bringing organized medical care into the incident plan when the conditions, the command, and the local policy allows it. Now, that distinction is important because it keeps each discipline focused on its assigned mission, right? So, for EMT level responders, the fire and EMS role is going to begin with rapid casualty identification and the triage, right? The goal is to determine who needs immediate help, who can move with direction, who must be moved by rescuers. So, in this environment, triage is not meant to be slow or overly detailed. It's really meant to support life saving care and that casualty movement. Fire and EMS also provide the basic interventions that keep patients alive really long enough to reach that safer definitive care. Now, at the FRO level, that just means recognizing immediate life threats, applying approved care within your scope. Okay. The detailed skills like bleeding control, airway positioning, chest injury care, hypothermia, shock prevention, this is going to be covered later on, but the role is going to begin here, right? Identify life threats and act within the grand plan. Now, packaging and movement are also part of the medical mission. A casualty may need to be moved from the point of injury to a casualty collection point, maybe then to a treatment area, and then from treatment to transport, right? So, fire and EMS just help make that movement organized rather than random, right? The CCP is where rescue begins to connect with treatment and transport. Now, fire and EMS may help receive casualties, maintain accountability, support that triage function, and then prepare patients for movement to transport resources. The CCP, which we're going to talk about, it's not the end point, it's just the part of the patient flow. Lastly, the fire and EMS support transfer to higher level care, right? That may mean, transport crew, ALS provider, system destination, or a hospital team. The handoff must preserve the essential patient history, but the full MIST structure will be addressed a little bit later on. So the fire and EMS role can be really summarized simply by, find the casualty, treat the immediate life threats, move patients towards safer care, and then connect them to the EMS and trauma system. Now, every responder at the BTCC incident has a specific role, but there are responsibilities that apply to everyone, right? First, we work through the ICS and the NIMS, okay? In a multi agency incident, the structure is what's really important. ICS and its command system gives the response a chain of command, assigned roles, different reporting pathways, and just a way to organize the resources. Where the NIMS or the NIMS supports a common approach across different agencies. So, law enforcement, fire, EMS, and just mutual aid partners can operate from the same real general framework. Okay. Now, secondly, we support unified command, right? Active law enforcement incidences can involve several priorities at the same time: threat mitigation, rescue, medical care, staging, transport. So, unified command just helps those priorities become one real coordinated incident plan rather than several agencies working independently. Third, we use common terminology, right? Hot zone, warm zone, cold zone, CCP, rescue task force. They all need to mean the same thing to everyone on scene. That shared language is just going to reduce confusion and improve overall safety, right? Communications, that should be brief, clear, concise, directed to the right channel. In these incidences, radio traffic can become crowded very quickly. So, good communication gives the information needed without that unnecessary detail. Situational awareness also belongs to every responder. Know your assignment, your location, your route, your team, your next destination, and really what has changed since that last update. And then lastly, we don't freelance, right? Acting independently may feel helpful in that specific moment, but it can really disrupt the accountability. It creates responder risk, and it delays that organized patient care that we're trying to get. So, in basic tactical casualty care first responder operations, discipline is really a major part of safety. Now, the EMT. Now, our role in basic tactical casualty care first responder operations is to function as an EMT level medical responder within the coordinated public safety response. That simply means your value is not based on how far forward you go or how much risk you take, right? Your value is based on recognizing life threats, applying approved basic care, help move casualties towards safer care, and really communicating clearly to the next provider. Now, you also need to recognize when conditions exceed your training or assignment, right? So, if a situation requires a higher level of care, requires additional personnel, law enforcement protection, more equipment, or maybe a different operational decision, you need to communicate that early through the appropriate channels, right? Requesting resources early is actually part of good patient care. Multiple casualties, severe bleeding, chest wounds, having limited equipment, pediatric patients, or just movement barriers, those should all really trigger early communication. At this FRO level, approved life saving care is going to include those basic interventions that we're going to teach in this course, right? The specific procedures will be practiced later in lab. But again, the role begins with just good decision making, right? Identify the immediate life threats, choose an approved intervention, and then stay within your assigned function. Now, again, we've talked about this, but movement is also going to be a major part of the EMT and the first responder operations role. A casualty may need help getting from point of injury to a CCP, from the CCP to treatment, or from treatment to transport. So, all your movement should always be purposeful, should be coordinated, and followed by a reassessment. And then lastly, provide concise patient reports. A clear handoff is going to prevent, again, important information from being lost as that casualty is going to move throughout the system. Now, let's go ahead and talk about the operational zones. And the BTCC care is going to be organized and such. So you have the hot, warm, and cold. Okay. The hot zone is really where the direct threat environment is. Care here is extremely limited because the immediate hazard is still present. So the focus here is just movement to safety, self aid when appropriate, and only the most essential life saving actions. Now, the warm zone is the indirect threat environment. The immediate threat has been reduced enough that assigned rescue and medical activity may happen, but the area is really not the same as a routine EMS scene, right? Care is really focused on rapid life saving interventions and just moving towards safer treatment. Then we have the cold zone is really the evacuation care environment. This is where reassessment, documentation, transport coordination, and just transfer of care become more complete, right? A key point is that these zones are going to be dynamic. They are not just labels attached to a building, a hallway, a parking lot. They really reflect the current threat, access, command decisions, available protection, and the route status. So a warm zone can become unsafe. A cold zone treatment area can move, and a route that was open may close. So for EMT level responders, the practical rule here is that you need to confirm a zone status before you act. Don't assume. Don't self deploy. Your care priorities are going to be dependent on the zone, and your entry is going to depend on your assignment, your local policy, and what is the actual command direction. Now, let's kind of break down each zone a little bit in more depth, right? So the hot zone, this is going to be the most restrictive phase of BTCC care. An immediate or direct threat is still existing, so that medical care is going to be limited to what can be done quickly and safely. The priority, again, is not a complete assessment. It's simply the priority is going to be survival through that immediate threat. Now, if the casualty can move, you're going to direct them towards a safer position. If they are alert and capable, direct them to have self aid when it's appropriate or needed, like holding pressure or applying their own tourniquet if they have one and can do it, right? So, if the casualty cannot move, that's where extraction may be needed, but that really decision belongs within the rescue plan and the command structure. EMT level responders do not independently enter this direct threat area. The main medical intervention considered in this phase is going to be controlling life threatening extremity bleeds, again, usually with a tourniquet. If stopping to apply the tourniquet would create a danger, or at least create a greater danger than moving first, then that movement of the casualty may take priority. Okay. Airway care is generally deferred unless a rapid action is necessary, like throwing them in the recovery position, and if it can be done without delaying safety or increasing the risk. Now, for EMT students, the hot zone care really should be remembered as minimal care, maximum movement, and then again, strict role discipline. Moving on to the warm zone. So this is where BTCC care becomes more active, right? But it's still focused. The immediate threat has been reduced, but the area is not fully secure in the routine EMS sense, right? That just means care has to be coordinated. You need law enforcement there to protect you, and is really tied to moving the casualty. Okay. A rescue task force may operate in the warm zone, again, if the policy allows it and authorizes it. So that requires a command assignment, law enforcement protection, communication equipment, an identified route, and really a destination for all those casualties. Okay. Now, the medical priorities are still going to be rapid life saving interventions, control major bleeding, position the airway as needed, seal any open chest wounds, prevent heat loss, and then again, prepare the casualty for movement. Now, the detailed skill steps will come later on. For now, just focus on the sequence, treat the life threats, and then move the patient. Okay. Warm zone care should not become this prolonged treatment in place type of protocol or procedure. The goal is just to stabilize enough to move the casualty towards a CCP or to a cold zone treatment area. That's where the reassessment and that transport coordination can continue. Now, situational awareness, okay, this is going to be continuous. Conditions can always change, routes can change, and the team may need to withdraw or redirect. Warm zone care really only works when the medical action, the protection movement, and the communication all really stay interconnected. Now, uh, our last zone is going to be the cold zone. Okay. Now, the cold zone is typically the evacuation care phase of BTCC. In this area, there's no identified active threat that's really affecting patient care. But again, that doesn't mean the incident is over, and it does not mean the responders stop using that specific command structure. It simply means that the environment is usually safe enough and allows more complete reassessment, better organization, and just more deliberate movement towards transport. The main shift here in cold zone care is from that rapid survival actions to continuity of care. Okay. Early interventions need to be checked: tourniquets, dressings, chest seals, airway positioning, mental status, signs of shock. They all might change after you move the patient. So, packaging also becomes more realistic here, right? The casualty may be prepared for ground or air evacuation, maybe move to a treatment area or transfer to the transport personnel. Documentation again should travel with the patient whenever possible. Destination decisions again remain local policy driven. In Los Angeles County, that just means using the current trauma system guidance and not relying on just your memory of the closest hospitals. For EMT students, cold zone care just means to reassess, organize, document, communicate, and just keep the patient moving forward towards that definitive care. Now, operational zones, these zones can change kind of rapidly as the incident changes. Okay. A hallway, a room, parking lot, a courtyard. So it's not permanently hot, not permanently warm or cold, just because it was labeled that at some point, right? The threat may move, new information may be reported, an access route may close, a casualty collection point may need to relocate. So really, this is why the responders really have to avoid making assumptions. So before entering or re entering an assigned area, just confirm the current zone, the route, the objective, what communication channel is being used, and what is the destination for the casualties. Now, this is especially important for EMT level responders because your care priorities really depend on what zone you're in, right? So, in that direct threat area, care is going to be limited. In that indirect threat area, life saving care can occur, but it also has to remain tied to the movement of the patient. In the evacuation care area, that's where that reassessment, transport coordination, that's where that is completed. So the safest habit is to just treat zone statuses as just current information, not old information. So if command has not assigned you, um, don't self deploy yourself. Now, cover and concealment. So, cover and concealment are just safety terms. They're not tactical skills for this course, right? Cover is going to reference to something that may reduce or stop a hazard. Concealment hides a person or position. But may not provide protection, right? So, a responder who confuses concealment with cover may feel safer than they actually are. So for EMTs, really the purpose of these terms is route your awareness and responder safety, right? You may hear law enforcement or command refer to available cover, concealment, protected routes, or extraction lanes. But understanding the terms is going to help you follow direction and just avoid unnecessary exposure. The medical care should not really place the team in a worse position when a safer option is available. So, if a casualty can be moved in a short distance to a more protected location before longer intervention, that may be a better choice within the overall rescue plan. But the key boundary is important here. So BTCC FRO does not teach tactical movement. Okay, so you just follow law enforcement direction, use assigned routes, and just keep medical care connected to the overall safety of yourself and the scene. Now, the casualty collection point, again, this is the CCP. This is a key concept, okay, because it helps turn a real chaotic casualty scene into an organized kind of patient flow process. So, a CCP is, in short, a temporary location where casualties are gathered for triage, for treatment, tracking, and movement. So it's not necessarily a hospital style treatment area. It could be a hallway, it could be a room, a corner, maybe just some staging area, or just some random spot that is designated by the command. The exact location simply depends on the threat environment, how many numbers you have, what routes are available, is there any protection available, and what transport access do you have. So the purpose of a CCP is really about organization. Okay, without a CCP, patients may be scattered across the incident area. Responders may duplicate efforts. Transport crews may not know where to go, and overall, the command may not have accurate patient counts. A CCP really creates a shared point of casualty flow. Patients move from point of injury or rescue locations towards a place where they can be sorted, reassessed, treated, tracked, and then moved again. Now, EMSA guidelines really identify both dynamic and static CCPs. So, a static CCP is more a stable location that remains in place for an extended period of time, whereas a dynamic CCP that could shift as the incident evolves. So, in an active law enforcement incident, a CCP may need to move if the threat changes, routes change, if casualty flow changes, or if the transport access improves. So students really should not think of a CCP as a fixed address, but it's like a functional location that just supports the mission. A good CCP should support protected ingress and egress. Ingress is just how teams bring casualty in, where egress is how casualties are moved out. If the CCP is easy to reach but hard to evacuate from, it may not serve the patients that well, right? If it's too close to the threat, it could be unsafe. If it's too far from transport, movement's going to be delayed. So the best CCP location is going to be a balance between safety, access, treatment, and transport flow. Now, at the CCP, interventions really should remain focused on life-saving priorities. Those massive bleeds should be reassessed, tourniquets checked, airway and breathing reassessed, chest seals should be inspected, hypothermia prevention should begin or at least continue. Casualties really may be tagged or tracked according to local MCI policy. So, missed information should start to become clear. Um, Really, the CCP also connects the rescue operations to the transport operations. So the rescue side asks, how do we reach and move casualties out of the threat affected areas? Where the transport side asks, which patient goes next, by which ambulance, to which destination? So the CCP helps bridge those questions. Now, for EMTs, the practical duties at a CCP, they're going to include receiving the casualties, controlling bleeding, reassessing those earlier interventions, assisting with the triage, helping move patients to transport, and then just communicating patient counts. So all of that is just going to depend on your assignment and your policy. Okay. The most important concept is just that at the CCP is not just a location, right? It is a patient management function, right? A well-run CCP helps casualties move from injury to treatment to transport, really without losing information, without losing interventions, or just accountability. Now, a rescue task force or an RTF, this is going to be a protected rescue and medical element. Okay. Now, the usual concept is that law enforcement protection is paired with fire or EMS medical capabilities. So, the purpose really is to reach casualties, provide rapid life saving care, and then move them towards a CCP or cold zone treatment area. Now, an RTF is formed under command direction and local policy. It should have a leader, an assigned objective, protected route, communication, medical equipment, and really an identified destination for all of those casualties. So for EMTs, the boundary is pretty clear. An RTF is not an offensive tactical team, right? Medical responders do not become law enforcement, do not search for threats, do not perform room clearing or any type of weapons related task as part of the BTCC FRO. Now, your role is simply, if assigned, is medical and movement focused. Okay, reach the casualty, perform the approved life-saving care, really help move the casualty, and stay with the assigned route and objective. The overall RTF success is going to depend on discipline, right? The team works because protection, medical care, movement, and the command direction, they all stay interconnected. Now, a contact team, this is going to be law enforcement driven. We kind of talked about it a little bit earlier, but its priority is just locating and mitigating the active threat, right? So, in some incidences, that may mean law enforcement moves past those injured casualties in order to stop the source of that ongoing harm and that threat. Now, again, I talked about this as from an EMS perspective. That can feel counterintuitive because our instinct as medical providers is to stop and treat. But if the threat is still producing casualties, stopping that threat is the first law enforcement priorities. For an EMT, the reason we discuss the contact team is just terminology. You may hear the term during an active law enforcement incident, and you need to understand what it means so you do not confuse it with your specific role, right? So the medical responders, again, do not perform the contact team function in the TTC FRO. Okay, you're not being trained to search for threats. You're not being trained to make those tactical law enforcement decisions. Right now, the key distinction is that the contact team addresses the threat. The medical and rescue elements address the casualties when it's assigned and when the conditions are allowing for it to happen. Now, the rescue team, again, talked about it. It's going to focus on casualties, not threat engagement. The mission here is to reach injured patients, provide rapid life saving care, again, when it's appropriate, and then move the casualties towards that safer locations like a CCP or a cold zone. Now, a rescue team may include that law enforcement, could include fire, EMS, other public entities. It all depends, again, on your local policy. Now, in some systems, the function may be organized as that rescue task force. Um, but it all depends, but the terminology may differ. Okay, so the important point is that EMT students and EMTs alike that the rescue teams operate under assignment, right? They should have a known objective, a known route, communication plan, and then again, understand where they should take the casualties. Medical care during rescue ops remain, again, basic, time sensitive, treat the immediate life threats, keep the casualty moving through the incident flow. And once again, we're going to go deeper into those skills, specific skills later on. But again, your role simply in this specific role is to access the patient, treat, move, and then communicate, all while just staying inside of your scope of practice. Now, the incident command system, so ICS and NIMS, again, sounds very administrative. Okay, you guys all should have some familiarity with ICS, but we'll dive a little deeper into it. When it comes to basic tactical casualty care FRO, they're more of a practical safety tool. The incident command system, right? The whole purpose is to have organized roles, reporting relationships, resources, and just objectives, right? It just helps you answer certain basic questions like, hey, who's in charge? Who do you report to? What's the assignment? Where do resources go? Who's tracking patients? Everything that's a part of the incident should be found in this incident command structure. Now, in terms of NIMS, the National Incident Management System, this is going to provide a broader, like, common structure that's going to help multiple agencies just work together. Um, the Federal Emergency Management Agency NIMS training really describes NIMS as a kind of a comprehensive approach that helps government, non-governmental organizations, private sector partners, and just other responders be able to work together to prevent, protect, mitigate, and respond to various incidences. Okay, so in a BTCC event, that common structure is going to be important because law enforcement, fire, EMS, hospitals, they all have to be involved and they all will be involved. So having that unifying structure is going to make things more applicable and efficient. Now, for an EMT, the most important concept is going to be reporting through assigned channels. You should know who your immediate supervisor is, what group or unit you're assigned to, where's your staging area, and how just overall to communicate. Now, in ICS terms, unity of command really helps avoid conflicting orders. Just in plain language, it just means you do not take random instructions from multiple people and act independently, right? You follow your assigned chain. Medical care is going to support incident objectives. Okay, that may feel different from that routine EMS where the patient encounter is usually the center of your world. But in a multi-casualty active violence incident, each patient still matters, but the response must be coordinated across many patients and hazards. Okay, so if the command's objective is to move casualties from a warm zone to a CCP, medical care should support that objective. Now, if the objective is to organize transport by priority, patient reports and triage information should also support that process. Now, accountability protects responders and patients. Command needs to know who is deployed, where are they, what equipment they have, which patients are moving, and what resources are really needed. If responders just self deploy or leave their assignments without reporting, then the command loses accountability. Okay. That can delay rescue, duplicate efforts, overload the radio, and just create additional rescue needs, right? Freelancing it's especially dangerous in BTCC. A responder again might have the mindset I can just go help over there, but that action is going to pull a person away from a different task. It's going to move them into an unsafe area. It's going to interfere with the patient flow. So good intentions do not replace that command discipline. Now, the California EMSA FRO curriculum, this just requires knowledge of ICS, NIMS, mutual aid, unified command, command post staging, managing simultaneous priorities. Okay. Now, those topics really all connect to one centric idea. Okay. An organized response saves lives, right? In a tactical casualty care environment, medical skill without coordination is just incomplete. So the practical EMT rule here is know your assignment, report through those assigned channels, communicate, and don't freelance. The ICS and the NIMS are not separate from patient care. They are part of how a patient care becomes safe. It becomes trackable and effective during these real complex incidences. Now, a unified command. So, a unified command is used when more than one agency has responsibility for the incident. Now, in a active law enforcement incident, law enforcement, fire, EMS, again, they all have critical priorities at the same exact time. Law enforcement addresses the threat, fire, EMS support rescue, treatment, movement, transport. The unified command helps those priorities work together instead of competing against one another. The key point is that, the medical operations are still part of the incident plan. The location of staging, the route of casualties, the CCP, the transport flow, the resource request, they all connect through this command structure. So the unified command is also there to reduce conflicting orders. So if an agency operates separately, patients may be moved to the wrong location, resources can duplicate, and the responders may receive inconsistent direction. So your role is never going to be to run unified command, at least at this point in time. Your role is to understand that assignments, the routes, your objectives, and the patient flow decisions that come from that coordinated command process. Now, communication is really a safety skill when we're talking about BTCC FRO. So, before your deployment, you need to confirm the assigned channel or the talk group. Because in multi agency type incidences, they can involve several different types of radio systems. So, it's really unsafe to assume everyone is hearing that same information. So, you really want to use plain language, agency specific codes, again, and they're not going to be understood by everyone on the scene. So your clear words are usually the safer bet. Where are you? What do you have? What you need? And what casualties are moving. Okay. So you want to keep transmissions brief. Radio traffic can become crowded relatively quickly, especially when several agencies are operating at the same incident. Now, um, brief does not mean vague though, right? So a useful transmission gives, your location, what's the need, and the priority without any unnecessary detail. Patient count and priority updates should also move through the assigned communication pathway that's been determined. The command needs to know how many casualties are known, how many appear immediate, whether more resources are needed, and really whether the patient flow is changing. So, operational updates also matter in this situation. Zones, routes, CCP location, hazards, and any local duress type procedures. Okay, so these details are going to affect responder safety and the patient movement. But really, good communication keeps the medical response connected really to the incident plan at hand. Now let's talk about the command post and the staging area, right? So these are two very different parts of the incident structure, and both are directly affecting how BTC FRO responders actually function. The command post itself is where the incident priorities are pretty much coordinated. In these active law enforcement incidences, those priorities may include, threat management, rescue, medical care, casualty movement, how you're going to transport patients, what resources you need to request, and really what is the overall responder accountability here. Now, EMTs are not expected to manage the command post, but you do need to understand that assignments, routes, operational updates, they're going to come from that command structure. But now, when we're talking about a little bit more important, is going to be the staging area. So, staging is where resources report and wait for an assignment. It keeps people, vehicles, equipment, and just teams organized. In BTCC incidences, staging prevents responders from drifting towards like the scene before the incident plan is really ready to use them. So that may feel kind of slow, especially when the casualties are known, but uncontrolled entry can actually create confusion and just additional risk. So before deployment, responders should respond or rather report to the staging area. They need to identify themselves, confirm their assignment status, and really just prepare their equipment. That's going to include their PPE, communication equipment, medical kits, tourniquets, dressings, the chest seals, everything that they would need for their response. Um, and now, the goal here is to be ready before the actual assignment is given, not necessarily to discover that you're missing equipment after you enter the operation. So, assignments should come through that command structure. A useful assignment should really clarify who you are with, where you're going, what route you're using, and what your objective is, and really where casualties should be moved. Okay, so if any part of that is unclear, you need to ask before you're actually deployed, of course, and that's when the conditions allow it. Now, the staging can also move, right? So if the threat somehow changes, a certain route closes, the CCP relocates, or transport access changes, the staging may actually need to shift as well. So it's important to remain alert for updates and avoid assuming that the first staging location is the correct one. Um, for the entire incident. Now, for EMT level responders, it's just the important takeaway here is just that you need to report, prepare, wait for your assignment, deploy with a clear mission, and then above all else, just remain accountable. Now, the ingress and egress. So ingress and egress, they're just words, but in basic tactical casualty care operations, they carry a lot of safety significance. Ingress means the route into the assigned area, whereas egress means the route out. Now, in routine EMS, responders, you don't always think that deeply about the route after you reach the patient. But in a BTCC FRO kind of situation, the route is actually part of the care plan. A team that can reach a casualty but can't get the casualty out has not solved the problem at all. So before entering an assigned area, responders should know the planned route out, and really where the casualty is supposed to go next. That might be the CCP, a cold zone treatment area, an ambulance point, or just some other location that the command wants. So if the team does not know the egress route, the team is not ready. Okay. EMSA integration guides really emphasizes protected access routes, emergency egress routes, secure extraction lanes, safe refuge areas, rally points, and emergency evacuation procedures. So those terms may kind of sound on operational, but they directly affect patient care. So a secure extraction lane allows casualties to move towards treatment, towards transport. A safe refuge area gives the team a place to move if conditions suddenly change and become dangerous. A rally point helps regroup if the team becomes separated or has to withdraw from an area. Routes must be clearly communicated, and that really includes the route name, direction of the movement, or your entry point, exit point, CCP location, and any known hazards. Okay. So if responders use vague wording, that's when confusion happens, right? Use the east hallway to the gym, CCP is clearer than go that way, right? So in a noisy, stressful environment, those clear route language is going to prevent errors. Also, alternate routes should also be identified if it's possible. A primary route can close relatively quickly, so a hallway can become blocked. A law enforcement update may change the warm zone boundary. A casualty load may make one point kind of more impractical. A door that was open may be locked now. So a team that has an alternate route is better prepared to adapt without just freelancing. Now, extrication, or rather, extraction lanes, those support casualty movement. So, in basic tactical casualty care, movement it shouldn't be random, right? Casualties really should flow towards safer care. A protected extraction lane helps turn individual rescues into an organized kind of patient movement process. Now, in every team, move casualties, move casualties in different directions. Patient accountability and transport coordination becomes difficult. Okay, so you really want to reconfirm routes before your reentry. Now, conditions will change, and old information can actually become dangerous for your team. So it's really important for this team to for it's important to understand that a team may complete one movement and then be assigned to return. So before reentry, confirm whether the route is still protected, whether the CCP is still in the same location, whether the team has the same objective, and whether the communication just remains the same. Now, for EMTs, the idea is that patient care and movement are directly linked together. The best tourniquet application still needs a route to transport, right? The best chest seal still requires reassessment and evacuation. Your most organized, missed report still depends on the patient reaching that next provider. So before you move, you really need to ask yourself, where are we entering? Where do we exit? What is the backup route? Where is the casualty going? Who has confirmed the route? And now, if those questions, those simple basic questions are unanswered, you just need to pause, take a moment, and clarify all those answers through the assigned chain of command. Now, mutual aid consideration. So, mutual aid really becomes important when the incident exceeds the resources that are just readily available. Okay. In these certain BTCC events, that can happen rapidly. Okay. So, there may be multiple casualties, limited transport units, limited just medical personnel, equipment. Maybe just the scene is very large, or there's just several access points that need the same support at the same time. Um, Additional agencies in these situations may be requested to help with, rescue, treatment, transport, communications, just logistics. The challenge here is that incoming teams may not know the local plan, right? They may use different radio channels, different terminology, different triage tags, just different equipment overall, and just different assumptions about the RTF operations or warm zone access. So even when everyone is really well trained, differences in these local procedures can just create confusions, and if they are not clarified early, gonna just be detrimental for the entire scene. So that's really why common language is so important. Terms like hot zone, warm zone, cold zone, ingress, egress, uh, those should be consistent amongst all these different groups. So if a term is unclear, you just have to ask for clarification before you actually act on it. Now, incoming teams need a briefing, right? So, at minimum, they should know the current threat status, the command structure, communication channels being used, where's the staging locations, what route to use, um, where's the casualty flow, triage method. Those are like some of the basics, right? And it seems like a lot, but that is the basics that are needed for a safe implementation of this new squad or this new group, okay? And it also helps prevent assignment duplication. Okay. So without assignments, several teams may converge on the same visible problem while other important tasks are being neglected. Okay. So the command may need one team at the CCP, one team preparing movement equipment, one team supporting transport, and another team awaiting an RTF assignment. So it's very important that to work together, language has to be clear across all pretty much what we call standardization. And there should be also training done on these types of mutual aid elements. Now, simultaneous priorities. So during these basic tactical casualty care incidences, they rarely unfold in a very neat, checklist type order, right? So several priorities may be happening at the exact same time. Law enforcement may still be managing the threat. Rescue teams may be preparing to access the casualties. EMTs may be controlling the severe bleeds. Staging may be, organizing the resources. Ambulances may be positioning for transport. So things are all happening at the same time, and it can feel very chaotic. But really, the goal is to not make one person handle everything. The goal is to let different parts of the incident work at the same time under one really coordinated plan. Um, threat mitigation. So, threat mitigation remains a law enforcement priority. Now, that matters to you as EMTs because the threat picture is going to affect the zones, routes, access, and the movement of patients. So, if threat information changes, the medical plan may also have to change with it. For hemorrhage control maybe begin before the entire incident is fully resolved because it's a life threat. That severe external bleeding is just a time sensitive issue, and early bleeding control can be the difference between a casualty, reaching transport or deteriorating before they're actually evacuated. Now, the way we actually do bleeding control procedures are going to be covered a little bit later on and more in the lab. But the priority is going to begin right at this point. Casualties also need to be to located and to be moved. Some may self-evacuate. Some may need rescue. Some may arrive at a CCP before the full patient count is known. So really, that's why patient flow has to be organized relatively early and be a priority. Transport resources should also be staged before casualties are ready to leave. If the CCP fills with patients, but no transport plan exists, that's when patient movement is going to stall. Okay, so transport planning, treatment organization, and rescue activity should all be developed together, right? And it's the command's job to ensure a balance of safety, care, and evacuation. The EMT level responders, they support that balance just by staying in their assigned roles, communicating relevant changes, and just really focusing on the task that are given to them. So now we're moving into threat. So threat is an acronym that really gives us a simple way to just remember the major priorities during an active, violent, or tactical casualty care response. So it's important to understand that threat is not a patient assessment acronym in the same way that sample or OPQRST might be. It's really a mission priority framework. It helps responders understand how the major pieces of the incident really fit together. Like I said, law enforcement they're dealing with threat management, hemorrhage control, casualty movement, medical assessment, transport. So the first letter here is T, right? So that's going to be threat suppression. Now, for EMTs, this does not mean that you are going to suppress the threat. Threat suppression, again, is the law enforcement responsibility. Your role is just to understand that medical care cannot be separated from the threat environment. So if the threat is still active, then access, movement, treatment, transport, they're all going to be affected. Okay, law enforcement activity may need to continue while rescue medical resources prepare just for their specific assignment. Next, we have H, which is going to be hemorrhage control. Okay, so this is where the medical priorities become very visible. Severe external bleeding can again kill your patient rapidly. So in the BTCC FRO framework, early hemorrhage control is one of the most important life-saving actions. So depending on the situation, that may mean direct pressure, tourniquets, wound packing, pressure dressings. So the specific intervention is also going to be dependent on the zone, right? So the zone that you're in, the equipment that you have, and of course everything being controlled by local policy. Now the third part is the RE. Okay, so that stands for rapid extrication for safety. Now, this is a key BTCC concept. In these incidences, the casualty may not be able to remain at the point of injury for an extended period of time for that extended care. So, once the immediate life saving intervention is performed, movement may become the next priority. So, that movement may be from a warm zone to a CCP, from a CCP to a cold zone treatment area, or from a treatment area to actually transport. Extrication, again, is not simply moving fast, is moving with purpose towards really a safer, more organized level of care. Next, we have A, so that's going to stand for assessment by the medical providers. Now, after the immediate threat and movement concerns are addressed, medical providers can perform a more like organized assessment. Now, at the EMT BTCC FRO level, that includes reassessing bleeding control, airway, breathing, shock, their mental status, making sure you're identifying any hypothermia risk, and really just any interventions that have already been performed. Because the key here is reassessment, right? The patient's condition may have changed during that movement process. Now, finally, we have T. Now, that stands for Transport to Definitive Care. Field care itself is not the endpoint, right? The casualty needs to move into the EMS and the trauma system. Now, in LA County, that means transport and destination decisions have to follow your local protocol, including adult and pediatric trauma considerations. A tourniquet, chest seal, wound packing, that's all going to buy time, but really it's definitive care that's going to be required and transport to an appropriate facility that's going to make the biggest difference. So when you hear threat, think beyond just a single patient, right? Think about the incident as a sequence of linked priorities. The threat has to be managed, bleeding needs to be controlled, casualties have to be moved, medical assessment has to continue, and then transport needs to be organized. For the EMT, it's important that you understand you may not own every part of this acronym, but you need to understand how your part fits into the whole response. Law enforcement handles threat suppression. EMT focuses on hemorrhage control, basic life saving care, movement support, reassessment, communication. The transport coordination that moves the casualty towards that definitive care. The strength of threat is that it keeps everyone oriented to the same outcome. You want to reduce those preventable deaths by combining safety, life saving care, that rapid movement assessment, and then finally the transportation. Now, the rescue task force should be formed deliberately, right? The RTF formation really begins with the command direction. Okay, that means the team specifically is created because the incident structure has, identified a mission, identified the route, casualty care objectives, and just a destination for the patient movement. An RTF is not just a group of responders who, like, independently decide to move forward because they hear, patients are injured, right? There's a clear team leader. There's going to be the team leader here should be responsible for like keeping the team together, maintaining communications, following the assigned objective, and really coordinating their movement as a whole. Every team member should know who is giving movement directions and really who is communicating with the command. Law enforcement protection also has to be confirmed, right? In a common like RTF model, the law enforcement provides protection and just threat related direction, while the EMS or fire personnel, they provide that life saving medical care and that casualty movement. Now, that protection is part of what really allows the team to work in this indirect threat environment. Without command assignment and law enforcement coordination, these EMT level responders really should not enter that situation. Medical personnel and equipment should also be confirmed before they're deployed. The team should know who is providing medical care, who is assisting with the movement, what equipment is being carried, and really whether the equipment matches the expected mission. Now, at minimum, the team should be thinking about bleeding control supplies, just chest seals, airway adjuncts, gloves, shears, warming materials, and just movement equipment as it's indicated. Now, the briefing should include the objective, direction of movement. The objective itself may be to reach the known casualties, move them to the CCP, just support another rescue element, or just clear a defined, casualty access route, of course, under protection. Now, the direction of movement should be specific enough that team members understand where they are, where they're going to go, where the casualties need to be moved. The emergency egress and the rally point information should also be understood before the movement. If the route suddenly becomes unsafe, communication fails, or the team just becomes separated, the team should already know that the planned withdrawal route and the regrouping location. Now, again, for the EMT, really the pre-entry mental checklist is just the basic: who's the leader, what's the mission, who's providing protection, what equipment do we have, what route are we using, where is the casualty going, and then how do we get out if conditions suddenly change. But just understand the RTF formation is just about controlled access to the casualties, right? The structure exists so that life saving care and casualty movement happen within that coordinated safety plan. Now, warm zone RTF actions are really focused on the rapid medical priorities and again, that controlled casualty movement. The warm zone is really in an indirect threat environment. That just means that the immediate threat has been really reduced enough for these assigned rescue activities. But again, the area is still not managed like a normal EMS type scene. So your team really has to remain alert, coordinated, and just ready to move. This is where situational awareness will continue. Team members should know their route, team leader, casualty locations, their egress path, just everything we've talked to up to this point. It is easy to become task focused during a medical intervention, especially when bleeding is visible or a patient is in distress. In the warm zone, task focus really must be balanced with awareness of the team and the route. Okay. Available cover and concealment should be used when directed. Really, the purpose is not to teach, tactical movement, but to reinforce that patient care should not create that unnecessary exposure for the team. Now, if the team can perform the same life-saving action really in a more protected location, that option should be considered when the within the assigned actual plan. Now, these tactical casualty care principles really guide the medical work. The priority is always to address those immediate life threats that really impact survival and movement, like your major bleeds, airway positioning, and so on, right? Everything we've talked to about thus far. Now, again, we're going to go a little bit deeper into what exact treatment we're going to do later on. But again, you the warm zone pattern here when delivering these interventions, it's correct what will kill soon, right? Then keep the casualty moving. So we're trying to take care of those life threats and then continuously move them to a more safe location. Now, triage in the warm zone is going to be limited and kind of practical. The team may need to determine, who can walk, who needs that immediate assistance, who has uncontrolled bleeding, and who has to be moved first, right? But again, a more complete triage and treatment can occur once the casualty reaches that safer treatment environment. It's always the goal to move these casualties to the CCP or a cold zone treatment area. The warm zone itself is not really intended to be a prolonged treatment location. It's just a bridge between patient access and that more safe designated care. Also, re-entry should only occur if it's assigned, right? So after moving casualties out, the team may be directed to return, but again, re-entry is going to require an updated route, threat assessment, understanding the communications, and again, more mission information. Conditions again can easily change since that previous entry. Now, warm zone RTF performance should look fairly organized. Stay aware, use assigned protection, perform those rapid life saving care, move those casualties, and again, once again, do not re enter unless you are specifically directed to do so. Now we're moving on to again responder identification and personal protective equipment. Okay, so these two elements are all about safety and accountability. In this course, your PPE, personal protective equipment, is not just the gloves, eye protection. Depending on your agency policy and your assignment, that PPE may include ballistic vests, helmets, respiratory protection, eye protection, glove, high visibility kind of markings, and just a plethora of other equipment. But the key phrase, again, is depending on agency policy and your assignment. The PPE has to be issued, authorized, fitted when it's required, and just used according to your local procedures. Now, EMSA's active shooter integration guide really specifically identifies ballistic vests and helmets as PPE during the preparatory actions, and it also emphasized clear identification of these rescue personnel. The tactical medical planning guide also prompts teams to consider these PPEs like the vest, like the helmet, um, but mainly based on the threat assessment. So now that does not mean every EMT is automatically expected to wear, a bulletproof vest as a part of their PPE. It just means that the need for PPE must be addressed and assessed and also matched with your policy. Okay. Now, clear identification is very important because, again, multiple agencies may be operating together. Law enforcement, fire, EMS, ambulance providers, public safety personnel, they could all be on scene. Okay. So, in poor visibility, high noise, high stress, these responders need to be identifiable. Okay. Clear rescue or EMS identification really helps reduce the confusion, it supports accountability, it really helps law enforcement recognize who is a part of the assigned rescue element. Now, medical equipment is also part of this readiness plan. The RTF should not begin with responders asking, where the tourniquets are, right? These assigned medical equipment should be carried in a way that is accessible and secured. Now, the Los Angeles County equipment list and the IFAK guidance emphasize like items like gloves, shears, dressing tourniquets, hemostatic dressings, chest seals, and transfer equipment. Okay, so the exact kit is going to be specific on your agency policy, but again, the principle is going to remain the same across all policies, and and that is that you train with what you carry and carry what you are authorized to use. So PPE does not make a responder, invincible. This is a point worth kind of saying just specifically and plainly. A ballistic vest, a helmet may reduce certain risks, but it does not eliminate the danger, right? Your respiratory protection may reduce a certain exposure, but only if it's if it's the right equipment for the right hazard and if it's used correctly. Your gloves, they reduce contamination, right? But they don't replace scene awareness. Just PPE is just a layer of protection, just not a permission, to ignore the environment. You want to avoid unnecessary exposure. If you don't need to stand in an exposed area to perform care, don't do it, right? If a casualty can be moved to a safer position before, longer intervention, consider that within the plan, right? If your equipment is not adequate for the assignment, say you need to say something before you're deployed. Reporting a PPE limitation, it's not a failure, it's just professional risk management. Okay. Now, threat assessment purpose. Now, this is really a structured way to think before you act. Okay. Now, in routine EMS situations, scene size up, you just ask basic questions, right? What happened? Is the scene safe? How many patients are there? What resources do I need? But now BTCC threats assessments really build on that same foundation, but it just adds the reality of working in these active law enforcement incidences. Because we're talking about the access, evacuation routes, additional PPE, and just overall what system resources are available. Now, the first purpose is to really identify those hazards before you act. These hazards can again can include weather. Is it hot, cold? What's the wind? Are there hazardous materials? Is there smoke? Is there explosive, structural damage, biological concerns, animals? Just any type of environmental threat. Now, again, the goal is not to make the EMT, you know, hazard specialists, if you will. The goal is to recognize when the environment can injure responders, worsen the patient outcomes, or just change your rescue plan. Now, the second purpose is really to estimate casualty needs, right? The team should think about likely number of patients, age groups, injury patterns, special pops. Are there any limitations in the ability to move a patient, and what are our available resources? Now, a small number of like critical patients may strain resources just as much as a large number of minor patients. If bleeding control, transport, or evacuation is difficult. So, access problems should also be anticipated early on. Can responders reach the casualties? Are routes blocked? Are doors locked? Are there multiple floors? Are there crowds? Are there any type of law enforcement restrictions on your movement? Okay. Evacuation problems, again, are just as important, right? Reaching the casualty is only half of the mission. The casualty must also move towards that CCP, that treatment area, that transport area, so they can get to that more definitive care. Now, special populations also should be identified early because they change communication and overall movement needs, right? Pediatric, geriatric, disabled, pregnant, language barriers, they require different support and therefore different planning, right? So it's important to understand what you're working with. Now, the threat assessment supports both the responder safety and patient survival. It helps the team choose the right equipment, request the right resources, use the right route, and just move the patients through the system, and just overall with just fewer delays. Perfect. Now, medical intelligence is really the patient-centered part of the threat assessment. In this first responder ops class, intelligence does not mean secret information or law enforcement investigation. Right? For the EMT, it just means gathering the practical medical information that just helps the team anticipate what the patient may need, what equipment might you need, and what barriers may affect care and overall the evacuation. So the first item is going to be the mission type. Okay, needs of an active violence incident at a school may look different from an incident, at a concert venue, at a government building, at a train station, sporting event. Okay, the basic uh, BTCC priorities are going to stay the same. Stop bleeding, manage airway, prevent shock, move casualties, communicate. But really, the setting changes what is likely to actually happen. A school may raise more of a pediatric consideration. A large, outdoor venue may create crowd movement and access problems. A transportation type hub may involve, multiple entrances, limited egress, large number of walking wounded. Um, the second item here is the estimated number of casualties, right? Early casualty counts are often like incomplete, but that's expected. Now, what matters is communicating the best available estimate and really updating it as information improves, right? Um, a report of like one patient leads to a very different resource response than a report of multiple casualties, unknown severity. So, casualty estimates affect, the tourniquet needs, dressing needs, litter needs, CCP staffing, ambulance staging. Um, so, it just the command needs all of this information to just be able to make that actual threat assessment and a plan. Now, the third item is age groups that are involved, right? Now, age matters because, pediatric, geriatric, adult, pregnant, they're going to require different types of communication, different movement, different triage, and overall, may potentially different destination considerations. A child may not be able to describe symptoms clearly, an older adult may have limited mobility, anticoagulant use, chronic medical conditions. A pregnant patient may require additional, again, destination or assessment considerations. So again, BTCC FRO does not turn the responder into a pediatric or an OB specialist, but it does require awareness that one casualty is not the same as one, standardized patient. Moving on. So the fourth item here is known pre-existing condition. Okay, so in these very chaotic, fast-moving events, you may not be able to obtain a detailed medical history, but sometimes information is available from the patient, caregiver, bystander, medical alert tags, um, anyone on scene, right? Diabetes, seizures, previous MIs, respiratory conditions, mobility issues, certain drug use, oxygen dependency, all that can affect how the patient presents and what resources may be needed. So even when the primary injury is, trauma, the patient's baseline health can influence deterioration and those evacuation needs. The fifth one here is special populations. The EMSA guidelines specifically mention peds, geriatrics, disabled, language barrier pops as important and explicit medical intelligent considerations. So in the field, this may mean a patient who cannot, self-evacuate, can't hear instructions, can't understand English, use the wheelchair, is dependent on a caregiver, needs assistive equipment. So and all of those are different factors that should be thought of first. Okay, they can really determine whether the patient can follow commands, maybe self-treat, walk to a CCP, tolerate a drag, or provide just a reliable history of what's going on. Now, the final category is other patient-specific concerns. Okay, this could include a large number of separated families, patients with service animals, patients with limited ability to communicate, patients trapped in certain locations, patients whose injuries are not immediately visible. Okay, it can also include operational relevant information like multiple ambulatory wounded moving towards the north exit, or two non-ambulatory casualties that are remaining near the second floor stairwell. Uh, Really, a useful mental model here is known, presumed, and unknown. Okay, what do we know? What can we reasonably presume based on the mission type? And what remains unknown and needs to be updated? So, that approach really prevents overconfidence while still allowing responders to prepare. Really, medical intelligence should not delay life saving care. If a patient is bleeding out, you need to control the bleeding. But even while interventions are happening, someone should be thinking about the patient numbers, patient types, movement needs, resources. In these environments, that information is going to help the incident move again from the individual rescues to that organized casualty care situation. Now, environmental and hazard assessment, this protects both the responder and the patient. Okay, in the BTCC FRO course, the environment is not just the background, right, in which you're working. Right, it directly impacts and influences patient access, the kind of injuries you're likely to see, what PPE is required. Uh, Potentially how quickly a patient is going to deteriorate, and really how safely casualties can be moved from one place to another. A responder who ignores the environment may choose the wrong route, underestimate the PPE need, move a casualty into a more dangerous location, right? So it really starts with the weather and the temperature. The heat, cold, rain, wind, snow all change the operation. The heat is going to increase responder fatigue and dehydration. Cold increases hypothermia, risk for trauma patients. Rain can make the movement more difficult, reduce visibility, compromise, your dressings and your treatment. Right, wind can affect smoke, chemical exposure, debris, um, air medevac operations. Temperature can also impact the casualty. Trauma patients can become, hypothermic. Now, next, consider hazardous materials, right? A tactical casualty care event may include, chemical exposures, fuel, industrial materials, random powders, contaminated clothing, or just unknown substances. At the EMT FRO level, the priority is going to be recognition, isolation, notification, and just following local hazmat procedures. Okay, do not move into an area simply because you can see a casualty. A contaminated responder becomes another casualty and actually can spread that contamination into the CCP, the ambulance, or even the emergency department. Another one is explosives or IEDs. Um, you have to consider it in this kind of in this realm. EMSA specifically lists these explosive threats and improvised explosive devices as part of the medical threat assessment. The BTCC FRO does not teach, explosive device recognition or, tactical like search procedures. Your role is just to remain alert for suspicious circumstance, right? Follow law enforcement, avoid disturbing suspicious objects, communicate hazards through the assigned channel, and just maintain distance according to your local policy. Chemical, biological, radiological, nuclear threats are also listed by the MSA's threat assessment guide. For you, really the correct level of understanding is hazard awareness. Okay, you're not trying to have training and whatnot in technical decontamination. Um, that's something you can do later on. But if there is concerns, PPE, decon, casualty movement, ambulance contamination control, and hospital notification, again, all of that could change. Okay, so your local policy and just specialized resource control is gonna be in charge of this whole circumstance. Now, the PPE needs and limitations should really be identified before the assignment. Again, your PPE may include gloves, eye protection, respiratory protection, that bulletproof vest, etc., that we've already talked about. But it's important to know that PPE is not universal, right? And it's not unlimited, right? So if a responder does not have the PPE that's required for the assignment, that limitation has to be reported before they're deployed. So again, your hazard assessment should not create paralysis, right? It should create informed movement. The goal here is to just recognize these hazards early enough to request the correct resource, choose a safer route, protect these responders, preserve patient flow, and really prevent avoidable secondary casualties. Wow, medical resource planning just answers a simple practical question. Once casualties are found, how do they move throughout the system? Okay, so the staging area is going to organize responders and equipment before your deployment. It's really where the team confirms their readiness, communication, assignment, their route, and overall their equipment before moving towards that incident objective. Now, the casualty collection point, the CCP, now, that's the link between the rescue and the treatment. Casualties may arrive by, self-evacuation, a drag, a carry, maybe just RTF movement. The CCP specifically supports the sorting, life-saving care, tracking, and just the organized movement towards that transport. Now, the triage or treatment area may be at the CCP or in a separate kind of cold zone location, and that really just depends on the incident plan. But really, there is This is where reassessment becomes more complete and where treatment priorities begin to connect with the transport decisions. Now, hospital planning should focus on the closest appropriate hospital, not simply the closest building with an emergency department, right? Trauma, pediatric, burn, specialty care needs that could easily change the destination. So, in Los Angeles County, those destination decisions must follow current local policy and the current trauma center information provided by the EMS agency. Transport availability matters really early in this. Ground ambulances need to stage, need loading access, and routes that do not interfere with the law enforcement or rescue ops. Air transport, if it's relevant, requires a landing zone, planning, and communication. Now, most importantly, transport planning really should begin before that CCP is overwhelmed with patients. For you, really, medical resource planning just means thinking beyond that first intervention, right? Yeah, the tourniquet can control that life-threatening bleed, but the patient still needs to be triaged, moved, reassessed, transported, and then finally receive that definitive care. Now, the team health is really a patient safety issue, right? In emergency services, responders often focus so intensely on the casualty that they minimize their own condition. In a short incident, that's not really a big problem. But when the incident is prolonged, it's very high stress, high threat, multi casualty. That's when it becomes a serious, like operational concern. A dehydrated, overheated, exhausted, emotionally overloaded, or injured responder, they're going to be less effective and may actually just become another patient. So, EMSA's tactical medical planning guide just includes that team health considerations like medical records, exposure protection, hydration, food, nutrition, extended ops care, sleep, fatigue, rehab, or first aid needs all should be accounted for. Okay. Now, EMSA's active shooter guide also includes a post incident assessment for those responders' mental and physical health. Okay. So really, team health is not just an optional wellness topic, right? It's a part of the tactical casualty care planning. And again, it's going to start with hydration. Okay, responders may be wearing PPE, carrying a lot of equipment, moving a lot, operating in environmentally unfriendly conditions, and working under very high stress. So dehydration can actually reduce your physical performance. It can worsen heat stress and just impair decision making. So hydration really should begin before the responder feels that severe thirst. Okay. Now, in a prolonged incident, hydration has to be a part of the plan. You can't just kind of wing it, so to speak. Now, nutrition is kind of goes hand in hand with hydration, but not as much. But a responder who has not eaten, they're going to feel fatigue, irritable, poor concentration, and have overall reduced endurance. So in these very extended operations, food and electrolyte replacement is a must. Okay. Now this doesn't mean eating during an active rescue task, but it means command and the team leaders should plan responder support when operations extend over a certain period of time. Now fatigue. So fatigue again is going to be a huge hazard. Fatigue is going to impact your attention span, reaction time, communication, memory, and your judgment. So in a BTCC FRO kind of spectrum, that matters because the responder again makes rapid decisions, right? Tourniquet, direct pressure, move, treat, CCP, or transport. All of those types of situations are required by that responder to have a clear mindset. Okay. The fatigue here is going to increase the chance of missing something very important or making a very preventable error. Now, heat and cold exposure again has to be monitored. Heat illness can really develop when responders are going to work in those high temps, direct sunlight, heavy PPE, poor ventilation, and just overall prolonged exertion. Um, Cold exposure can affect both responders and the casualties, especially when it's raining, high wind, nighttime ops, or just extended outdoor staging type situations. So, a responder who is shivering, they're confused, overheated, weak, um, may not be safe to continue working in their specific assignment. So rehabilitation needs really have to be anticipated. Rehab can include rest, cooling, warming, hydration, just medical monitoring, replacing PPE, basic first aid, and then potentially a reassignment. Okay. So for an EMT, the important behavior is to just report these limitations early on, right? If you need to say, hey, I need relief, my PPE is compromised, I'm becoming overheated, it is not showing weakness, right? It's professional safety behavior. Uh, Now, last, which is kind of overlooked a lot of times, is the mental health aspect, right? So that's a very big part of team health. Active violence and mass casualty incidences can really expose responders to a lot of traumatic sights, sounds, have to make a lot of difficult decisions. So, the post incident processes could include and should include a debriefing strategy, peer support, um, and just follow ups by your agency. Okay. Now, the purpose of this is not to force everyone to, react the same way. The purpose is just to recognize that responder health includes psychological as well as physical functioning. Okay. Now, a useful team health principle is going to be buddy monitoring. So responders are often better at noticing changes in a teammate than themselves. So you need to watch for confusion, irritability, slowed movement, poor coordination, unusual silence, really anything that's out of the ordinary. Okay. And it's important for you to speak up early and really and route your concerns through the team lead or the command structure. Okay. Um, this is all about saving casualties. It's about saving casualties, but responders are a part of the rescue system. If the team fails physically or mentally, the patient care is going to suffer. Healthy responders are just overall safer responders, and safer responders provide just better care to the patients. So the individual first aid kit is really designed to support immediate life-saving care. Okay. Now, in this context, the IFAK is not really a general first aid cabinet, so to speak. It's a compact, organized kit that's really focused on the first few interventions that may present or may prevent rather early death. You have your hemorrhaging, chest wound management, hypothermia, basic airway support. Okay. Now, the kit may be carried by an individual responder, a team, or maybe both. And the exact configuration is going to be dependent largely on your policy, medical direction, and your role. But what matters most is that the equipment is approved, you're familiar with it, and it's organized for rapid access. The contents really have to match local approval. A responder may have seen a device in another course, online, another agency's kit, but that does not make it authorized to be utilized. Okay, the equipment must be approved, supported by agency policy, and just consistent within the scope of your credentials. Training also has to match the equipment. So if the agency stocks one tourniquet model, the EMT needs practice with that specific device. If the kit uses a specific hemostatic dressing, you be able to recognize the product and again how to use it. Now, the equipment does not authorize use, right? A skill may still be outside local scope, even if the item is physically there. This is especially important for airway adjuncts and certain scope equipment. So know where every item is stored. Under stress, searching through disorganized pouches is just going to waste time. The kit really should support just rapid and confident action. Find the tourniquet, find the dressing, find the chest seal, and then keep that patient moving. So, what's actually inside of this individual first aid kit? So, it should be organized around the injuries most likely to require that just immediate action. Okay. The medical pouch keeps equipment protected, organized, reachable. So the layout is very important, okay? Because again, in these stressful situations, a responder should not need to search through all these loose supplies in every little pouch. Okay. Trauma gloves support responder protection, standard precautions. Major bleeding does not remove the need for BSI. It simply just means the responder may need to act quickly while still protecting themselves as soon as feasible. The approved tourniquet is used for, life-threatening extremity bleeds. So it should be a device the responder has practice with, has quick access, and can apply quickly under a lot of stress. Because really, a tourniquet is not effective simply because it's present in your kit, right? It must be applied and tightened in the correct manner. Now, a pressure bandage is going to help maintain direct pressure after bleeding is controlled or almost controlled. It's especially useful when a casualty has to be moved and the responder can't keep both hands on the wound. Now, hemostatic dressing, again, has to be approved. It's used for severe compressible bleeding when a tourniquet is not appropriate or not sufficient. And really must be paired with wound packing and sustained pressure when it's indicated. Now, an vented chest seal is preferred for those open chest wounds. Um, and again, that's going to be to help prevent that tension pneumo. Um, but really, yeah, together, all of these items just support really the core BTCC priorities. And again, stop bleeding, manage open chest wounds, and preserve just again anything that's life saving interventions um, prior to movement of the patient. Now, some of the additional contents are going to support the same goal, right? And it's just keeping the casualty alive long enough for definitive care. Okay. And that includes the rescue blanket to prevent hypothermia. Uh, these trauma patients, again, can lose heat rather quickly after blood loss, after exposure, wet clothing, or just long contact with the ground. Now, the blanket, again, is not for comfort, it supports trauma care. Okay. A permanent marker helps preserve time sensitive information. Really, the most common is going to be just the tourniquet time. So, once the tourniquet is placed, the time should be written, it should be tagged, which is clearly communicated based on your policy. Trauma shears, again, one of the more common ones are going to be your raptors to expose the areas. Severe bleeding, chest wounds, any type of hidden injuries that can be covered by gear or clothing. Um, and again, exposure should be purposeful. Reveal what must be treated, and then protect the patient from heat loss. Roller gauze, elastic bandages. Again, that's going to help secure dressing, support wound packing, reinforce pressure. EMTs really should be comfortable handling all of these things efficiently. Okay. Um, the nasopharyngeal airway is also a part of the recommended EMSA individual first aid kit list, if you will. But again, it's only approved and you're able to use it if your agency allows it. Okay. Manual airway positioning remains really the foundation, but again, adjuncts can be utilized, whether it's an OPA or an MPA. Yeah, so the standard here is just, is all about local approval, training, and policy. So again, just understand what equipment you're able to use. And if you're able to use a piece of equipment, make sure you know how to use the equipment. Now, LA County training equipment really it really supports the hands-on skills that you're expected to practice and demonstrate. Goggles, glasses, those are going to reinforce eye protection. Bleeding control training, simulated blood, movement drills, close patient contact can all create, splash risk. So eye protection really should become a routine kind of habit. Um, Gloves also support these standard precautions in the lab. Gloves also help build the sequence of preparing for patient contact, really before performing bleeding control or airway related type skills. A pocket mask or a one-way kind of facial barrier device, that's going to again provide that little layer of protection. Now, BTCC FRO is not primarily a CPR course, but again, airway and breathing remain part of the care framework. So, barrier equipment just reminds students that responder safety continues even during these high stress type care situations. Now, trauma shears, those are going to be used again to expose injuries. So, students should understand both sides of exposure, reveal enough to find and treat those life threats, but avoid unnecessary heat loss or a loss of the patient's dignity. Okay. Now, the dressing materials, 4x4s, trauma dressings, Kerlex, that's going to support direct pressure, wound packing, dressing reinforcement, and just pressure dressing construction. Okay, the goal is to not create a neat bandage. The goal is to control bleeding and keep the dressing functional during movement. 2-inch cloth tape can also help secure dressings, but it does not replace that pure pressure or that correct placement or the reassessment. Training equipment really should be familiar before you actually are tested. So it's important to make sure it's not the first time you're encountering these items during the skills checkoff. So, skill equipment is going to be used so students can really practice performance. Again, it's not just about memorizing concepts. Commercial tourniquets are going to be used for the primary tourniquet skill. Students should train with approved devices used by the program because, again, different models have different routing, tightening, and securing type features. Improvised tourniquets may be shown to really teach different concepts of that circumferential pressure. But again, approved commercial devices are going to be preferred. Now, improvised devices are less predictable and should not replace those stocked approved equipment in the normal training expectations. The wound packing mannequin is going to allow students to practice that compressible hemorrhage control in a more immersive, realistic way. Wound packing is difficult to learn from just lecturing. Students really need to feel the difference between placing gauze over the wound and packing material like inside the wound cavity. The hemostatic dressings, again, have to be on the approved list. Um, the product approval really matters here because, again, not every commercially available product is authorized for California pre hospital use. The vented chest seal is going to support those chest injury management practices. Students really learn to apply it, ensure adhesion, and then again reassess breathing rather than just treating it as a simple like sticker. Emergency blanket supports hypothermia preventions during these trauma scenarios, so it should appear in practice so students remember that warming is really part of trauma care. Department specific litters, transfer equipment is going to prepare students for casualty movement. So, really, you should practice with the devices they actually could see in their agency and program environments. So, approved commercial tourniquets are really the preferred tool for life saving or life threatening, rather, extremity hemorrhage when a tourniquet is actually indicated. Now, the LA County BTCC FRO equipment list identifies that the commercial tourniquets allowed for training are listed right here. Okay. Now, soon you don't need to become a collector of all of these different type of tourniquets, but they you have to recognize that different devices have different straps, buckles, locking mechanisms, and tightening systems. Okay, so the competency really requires training with the device that's actually used in the course, and ideally the device that's stocked by your agency. Now, the reason commercial tourniquets are so important is because it's the reliability, right? So a proper tourniquet has to be wide enough, strong enough, and just mechanically capable of occluding an arterial blood flow in a specific limb. Okay. So not much to talk about there. We are going to kind of in a little bit go over the correct way to use a tourniquet, but I just want you to be aware that there are many different types of tourniquets. So it's important to have exposure and awareness of them. But again, you're going to practice primarily with the ones that you're going to work with in the field. Hemostatic dressings. So these are very important for bleeding control. But again, they have to be understood. A hemostatic dressing is not a replacement for direct pressure. It's going to be what we would call an adjunct. Okay, that means it helps the responder just control severe bleeding when it's used correctly, when it's used on the correct type of wound with the right technique. So the first rule here is kind of straightforward. You only want to use EMSA approved products. So in California, the EMS authority is responsible really for approving hemostatic dressings for pre-hospital use. Um, now that just means that the EMT should not select a product just because it's sold commercially, it's available online, it's used somewhere else in a different agency. Okay. Now for BTCC FRO, the product has to be on the EMSA approved list. Uh, but also be utilized by your local agency. Okay. Now, the second rule is that the hemostatic dressings are used for compressible bleeding. Now, compressible bleeding means that bleeding that can be reached and compressed with direct pressure. So, a deep wound in extremity, groin, axilla, shoulder, uh, those are going to be the more appropriate locations for wound packing and compression. Okay. So a wound is not appropriate for packing simply because it looks bad, right? So you have to ask yourself, can I reach the bleeding source, pack the wound, and hold pressure? So these hemostatic dressings are really useful when a tourniquet is not appropriate. A limb tourniquet works for severe extremity bleeds, but it does not work well for junctional areas like the groin, axilla, and the neck. In some cases, wound packing with gauze or an approved hemostatic dressing, followed by sustained pressure, a pressure dressing, that could be more appropriate. Okay. The third rule is that hemostatic dressings usually require wound packing, so not just surface coverage. So if the bleeding source is pretty deep inside a wound cavity, placing the gauze over the top is not going to control the bleeding. So the dressing needs to be packed firmly and deliberately into the wound space, really towards the bleeding source, layer by layer, until the cavity is filled. Okay, then you apply pressure. Now that pressure is important. The hemostatic agent helps like support clotting, but the physical pressure is really what compresses the bleeding vessels and just keeps the dressing in contact with the specific source. If a responder packs a wound and then just immediately lets go, the intervention is going to fail. So during lab, it's important to practice packing, holding pressure, and then securing a pressure dressing, and then reassessing. Now, after the dressing is already packed and the pressure is held, you got to secure it with a pressure dressing. The pressure dressing helps maintain the intervention during movement. It should be firm enough to really maintain pressure over the bleeding source, but the responder still should reassess. A dressing that looked good before movement can loosen after a drag, lift, or carry. Okay. Really, the most important part, at least for the performance part, is choose the correct type of wound, use an approved product, pack the bleeding source, hold the pressure, secure the wound with a pressure dressing, reassess, and then communicate. In the MIST report, your treatment should include the product that was used, the wound location, whether the bleeding was actually controlled, um, and whether the patient was moved after the intervention. Again, hemostatic dressing use is not complete until, again, the next provider knows that it actually happened. So here's just a list of the approved EMSA approved hemostatic products. Again, just be aware that again there are a lot of different products out there. Understand that they all pretty much have the same function, but again, just whatever you end up working with in your specific department or agency, just be familiar with it. So not a whole lot to say there. That's pretty much it. Now, so we just went over what was authorized, again, that little list, but now what's not authorized, okay, at least not yet. Now, the EMSA approved list specifically states that, hemostatic Celox granules are not authorized. But it also states that granules delivered in an applicator are also not authorized. Okay. So that just means that you should not generalize from, Celox gauze is approved, but all Celox products are good. So that's incorrect. Okay, so the form of the product actually matters as well. Gauze-based products can be packed into a wound, held in place, and secured. Right, these loose granules create kind of a different handling, training, and wound management issue. Okay, so for this course, you have to follow the approved list exactly the way it is. So you can't have any substitution, even though the product might be available um, commercially. Okay. So again, just be aware of what's out there. Um, for you, really, the practical behavior here is to check the package and know your agency's product, right? So if you're handed a hemostatic product that is not on the approved list, or it's not part of your training, don't assume. Ask, verify, and again, use what's approved. All right, so BTC care sequencing. Okay, so this is all built around different priorities. So, in a high stress trauma event, the responder has to know what matters first, right? This long assessment checklist could be useful in routine conditions. But during these tactical casualty care situations, the priority is to identify and treat the problem that's most likely to kill the casualty. Okay. Now, that is why the BTCC emphasizes a care sequence. Okay, your first priority: massive bleeding. So if a casualty is bleeding severely, that bleeding may kill faster than most other problems the EMT can correct in the field. Severe extremity bleeding may require a tourniquet. Compressible bleeding may require direct pressure, wound packing, a hemostatic agent, and then a pressure dressing. So the key is not just doing something, the key is really confirming that bleeding is controlled. The next part of the sequence is going to be the airway. So a casualty who can't maintain their airway, they're going to deteriorate. At this level, airway care usually means manual maneuvers like the head tilt chin lift or jaw thrust, um, putting in the recovery position for an unconscious patient, or the position of comfort for a conscious patient, all while protecting the airway, or applying a basic BLS airway adjunct. Okay. Then comes breathing, okay? Especially when we're talking about like injuries to the chest or the torso that's causing just breathing distress. More specifically, the open or sucking chest wounds. A vented chest seal is going to be the preferred method when available. A non-occlusive dressing may be used if it's in your scope of practice, or not really scope, it's in your scope of practice, but in your policies, if you will. After sealing it, the responder must reassess breathing, monitor for signs of like worsening respiratory distress, and then treat accordingly. Okay. The sequence here also includes shock and different circulation concerns. Now, at the EMT FRO level, shock recognition is very practical. Altered level of consciousness, pale, cool, clammy skin, weak or absent radial pulses, major bleeds, and just deterioration during movement. Okay, so treatment is going to begin with the bleeding control, hypothermia prevention, positioning, rapid movement, and then communication to the next provider. Now, hypothermia prevention comes early, okay? The trauma patients are going to lose heat very rapidly, and it can worsen the trauma physiology overall. So, covering that casualty, really and reducing the exposure, insulating the patient, that could actually pay dividends for the overall outcome of the patient. And then lastly, we have the reassessment, right? You want to reassess continuously. It's really what makes this entire sequence much safer. A tourniquet can fail, bleeding can restart, anything can happen. Anything that you fixed could become unfixed. Okay. So reassessment is going to be one of the most vital elements here to catch those changes before you actually transfer your care. Now, this whole sequence is not really meant to be a rigid in a way that it ignores the environment. Right, in a hot zone, movement may come before a full airway assessment. In a warm zone, you might be performing those life saving interventions while extracting. Whereas in a cold zone, reassessment and documentation that's where you're going to complete that. So the sequence simply is going to guide the medical priorities, while the zone guides what is realistic for the rescuer to actually do and complete. Now, Direct threat care priorities. So these are going to be your hot zone care or care under fire. And it's really the most limited phase of tactical casualty care. The environment drives the medical decision making. So when an immediate threat exists, the responder can't provide that routine trauma care. Detailed assessment, full vital signs, packaging, treatment of minor injuries are not the actual priority, right? The priority is survival through that immediate threat. So your first priority here is to move to a safe position. The MSA guidance here is to begin hot zone care with mitigating the threat and move to a safer position. So for EMTs, that wording needs to be interpreted through your specific role and scope, right? Law enforcement is going to manage the threat mitigation, where the EMT is going to respond and focus on movement, safety, and again, your medical action specifically. Now, if you're not assigned, protected, and operating under command, then you don't enter that situation. Okay. Now, the second priority is to direct really capable casualty to move. Okay. A conscious casualty who can walk, crawl, follow commands. They may be able to move towards cover, concealment, an exit route, or just overall a safer position. Verbal direction can be life saving. A responder may not be able to reach the patient immediately, but the responder can guide the casualty to move. Okay. The third priority here is direct self aid when it's appropriate. So, if the casualty is alert and capable and has access to a tourniquet or can apply direct pressure, they may be able to begin bleeding control before the rescuer can actually reach them. Now, again, that's a simple situation, but again, it's very important because self aid can buy time when physical access is going to be delayed. Now, the fourth priority is going to be extraction from that unsafe area. Now, again, EMSA identifies casualty extraction using manual drags, carries, soft litters, or just local specific devices. So, in hot zone conditions, the movement may be more important than actually completing that intervention. So, the decision is not just to treat or move in a more general sense. The decision is what action gives the casualty and this team the best chance to survive the immediate threat. The fifth priority here is going to be apply a tourniquet if it's feasible. So for life-threatening external hemorrhaging, that's anatomically amendable to tourniquet use. Okay, so that usually means that severe extremity bleeding. Um, Also, tourniquet application as it has been identified as the primary medical intervention to consider during direct threat care. Okay. So the word feasible is important here because if the situation permits rapid tourniquet applications without creating unacceptable risk, then you apply it, right? So if the movement to safety comes first, move first and then control bleeding as soon as possible. Now, tourniquet application in this phase, again, um, maybe hasty. That may mean high on the limb, over clothing, tighten until the bleeding stops, especially when the wound can't be exposed. But later in a safer place, the tourniquet should be reassessed. Right? Direct threat care is about immediate survival, not the perfect placement under those ideal conditions. Now, the final priority here is to consider rapid recovery position. Again, if the casualty is unresponsive but is breathing, and if it can be done quickly without delaying movement or just increasing the risk of the patient. Recovery position can help protect the airway, but in the hot zone, it should not become a long airway management sequence. The central idea here is that you want to have minimal care, maximum movement, and just strict role discipline. All right. So the direct threat care again is not the time for a lot of treatment. It's the time to move to safety, direct self aid, extract casualties, control those catastrophic extremity bleeding if it's feasible, and then protect the airway. Okay. Good EMT performance in this phase, again, is not measured by how many interventions are performed. It's measured by whether the responder makes those safe, fast, life saving decisions within the command and within your scope. So now, Threat care is usually associated with the warm zone. Okay, so the immediate threat has been reduced enough for assigned rescue and medical activity, but the area is still not treated like that routine EMS scene that we're used to. The care really here should be focused, should be efficient, and really connected to the movement of the patient. You want to control major bleeds. Look for bleeding that was obvious at first contact and bleeding that may have been missed during that rapid movement. Okay. Now, if a tourniquet is already in place, you need to check whether it's still controlling the bleed. If bleeding continues, the intervention has not fully worked and has to be corrected. And again, you're going to probably just apply another tourniquet, but we'll talk about that later. Now, next, you want to open up and position the airway. Now, at the fro level, airway care is mainly the manual and positional, so the head tilt chin lift or the jaw thrust maneuver, putting the person in recovery position or in a position of comfort. Now, airway adjuncts, again, if you're trained and it's in in your protocol in terms of your in your policy, you would drop an OPA or an MPA. Open chest wounds really should be sealed using a vent or an occlusive dressing. The vented seal is a preferred method when it's available. And after sealing, you want to breathing needs to be reassessed because really these chest injuries can always worsen over time, even after the appropriate intervention is in place. Previous interventions also should be reassessed. Again, a tourniquet applied quickly in a direct threat area may actually need more tightening. Dressing could shift, chest seal can loosen. Movement can actually turn a successful intervention into that failing one. Again, try to prevent hypothermia early on. Again, the casualty is going to be exposed through a lot of whether it's a cold surface or the wet clothing or just from bleeding loss. So again, put on that emergency blanket. And then again, prepare the casualty for movement, right? So indirect threat care is not meant to be that long-term treatment in place. Again, the goal is to correct those immediate life threats, protect those interventions, and then move the casualty towards a CCP or cold zone area. Okay. And we just to reiterate, you want to treat what will kill, reassess what has already been done, protect the casualty from heat loss, and then move towards that more definitive care. Now let's move on to evacuation care priorities. Okay. Now, evacuation care is the point where BTCC field care is going to connect with them more directly to transport so they can get that definitive care. And now, at this stage, the casualty is usually in a safer operating area than that hot zone, which allows the responder just to slow down just enough so they can reassess, they can like organize their thoughts, document what has been done, and then just prepare the patient for that next level of care. Now the pace is still urgent, but the work just becomes a bit more structured. Start by reassessing your major life threats, check airway, breathing, circulation, and again reassess all of your current interventions that have already been done. Your additional assessment can actually incur if the environment allows it. So check for any missed injuries, obtain vital signs, reassess mental status, and really identify any special concerns like the age, pregnancy, disabilities. Are there any burn injuries, any communication barriers? Again, the whole purpose is not to delay transport. The purpose is just to identify information that changes the priority, the destination of the patient, or just the handoff. Now, for the preparation for evacuation, it could involve ground transport, air transport, or just movement to a different treatment or loading area. Now, the destination and transport pathway should follow your policy and more specifically the incident plan. The An oral or written handoff also matter. A verbal report gives the next provider the immediate picture, but the written documentation is just really what helps preserve treatment details as the casualty moves through the system. Okay. A key expectation here is just a continuity of care. Reassess the patient, preserve information, and move the casualty towards the right level of care with the right reporting. Now, again, the reassessment is a life saving skill. And it's an important habit to ingrain into you for at the BTCC FRO level. And again, it's because any intervention that you've done, it could always fail, right? And so we need to be able to be aware of that and then to reassess and then retreat as needed. Um, so recheck at every intervention after a tourniquet. Look for that continued bleeding. After a pressure bandage, check to see if there's any soaking bandages or if there's pooling of blood. After a chest seal, reassess the airway, lung sounds to see if their breathing is worsening, and so on and so on. Really, the casualty may arrive at the CCP with an intervention that looked effective before you moved them, but then now it's no longer working. Okay. Also, assess their level of consciousness, right? So, depending on the situation, they might have some confusion, agitation, unable to follow commands, just have decreasing level of responsiveness. And that could be a result of their airway, of their breathing, or of their circulation. But now for you, you should just understand that reassessment should become automatic. Okay. You want to treat the patient, move the patient, recheck, and then report. So now recognizing life-threatening bleeds. So life-threatening bleeding, it needs to be recognized quickly, right? In BTCC FRO, the responder may not have time for that real methodical, slow assessment before actually applying that first life-saving decision. The environment can be noisy, chaotic, very crowded. So the casualty may be moving, lying in an awkward position, covered in clothing, so the recognition has to be practical and fast. Look for that spurting blood. Spurting or that pulsating blood is going to suggest an arterial bleed, and that is what really is an indication that it's a life-threatening bleed. So don't wait to see whether it slows down. You just need to control it immediately. Okay. Also, look for pooling of blood. A pool of blood on the floor, the ground, under the casualty. That can indicate significant blood loss. So. Uh, you also want to be careful at this point because blood can spread under the patient, into dark clothing, under furniture, behind them. So, if the environment is very cluttered, you're going to have to deliberately look under and around the patient. Also, look for rapidly soaking clothing or dressings. Okay, the clothing can be can hide the source, a jacket sleeves, pants, dark fabric. It can all actually hold a surprising amount of blood before the responder even notices. If the clothing or the dressing are soaking very quickly, just assume a major bleed until it's proven otherwise. A traumatic amputation is another major situation. So, if a limb or a part of a limb has been amputated, the responder should immediately evaluate for the severe bleeds and again, apply a tourniquet as necessary. If you have a mangled extremity, if it's crushed, deformed, partially amputated, they're gonna bleed very heavily. And again, you might not be able to find the bleed at first glance. So again, tourniquet placement may be needed when that severe extremity bleed is just there and you can see it, or if you suspect it. Shock signs with suspected bleeding also are very important. Sometimes the bleeding is not immediately visible. The casualty may be pale, cool, clammy, confused, anxious. The pulse may be rapid or weak. In a tactical casualty care sense, especially after like some type of penetrating trauma or blast injury, uh, don't be reassured just because the obvious blood loss seems small. Hidden bleeding can easily exist, and external bleeding can easily be missed. Um, so again, bleeding control is going to be the number one preventable cause of death. Okay. Um, Now, again, the first few seconds of this really matters. So you just have to ask yourself, is blood leaving the body in a way that can actually kill this casualty? If it's a yes, then you need to act, right? Don't wait for a full set of vital signs. Don't wait for the patient to become unresponsive. Uh, do not spend time treating minor wounds while major bleeding continues. Okay. Uh, a real easy BTCC habit is to just scan for blood with just purpose, hands, arms, legs, groin, armpit, everywhere. Okay. When major bleeding is found, use the intervention that just matches the location, right? Tourniquet for the severe external bleeds, and direct pressure and wound packing for those compressible, non tourniquet type bleeds. And then again, always reassess everything afterwards. Also, don't wait for late shock, okay, before you take bleeding seriously, okay? By the time a trauma patient has those obvious late shock signs, the situation is already critical, okay? Early in blood loss, the body will compensate. The heart rate's going to increase, blood vessels constrict, patient starts breathing faster. So the skin's going to become pale and cool, patient's going to turn anxious, maybe a little confused. The blood pressure itself can actually be deceptively, acceptable in terms of like what you would expect to see, but then it's going to fail rapidly. Okay, so if you wait for only a low blood pressure, then you've waited too long. Okay. Early bleeding can be hidden. Blood can collect under clothing, as we just talked about. So it's very important to locate that bleeding source and to treat it accordingly. And that could just be looking around the patient, cutting their clothes off to expose them. It's all about being thorough but rapid and efficient. Um, so the skin signs are probably one of the more pertinent signs and symptoms. If you have that pale, cool, clammy skin, these signs indicate poor perfusion. Okay. Um, they are not perfectly specific, and fear or environmental factors can actually affect the appearance. But in a trauma patient with suspected bleeding, that should be a huge concern. Okay. A rapid pulse, again, that could indicate just the compensatory mechanism of the body. So you really want to treat everything immediately when it's feasible. Um, and then again, don't wait till the very end where you're seeing all the textbook signs of shock before you decide to actually take it seriously. Now, direct pressure is one of the most basic bleeding control skills, but it really has to be performed correctly. Okay. Now, when it's appropriate, you need to expose enough of the wound to see where the bleeding is actually coming from. The exposure should, again, be purposeful, reveal the bleeding source, control it, and then protect the casualty from that heat loss. Okay. The pressure should be really firm and focused. A loose hand placed somewhere near the wound is just not enough, right? The pressure needs to compress the bleeding source. You want to use a gloved hand, gauze, or some type of dressing material to apply the pressure directly over the bleeding point. You're going to maintain continuous pressure. Now, a common mistake is just repeatedly lifting the dressing to check whether bleeding has stopped. Now, that actually interrupts the clot formation and can restart the bleeding process. So if blood soaks through, you just add more material and continue pressure rather than removing the dressing. Direct pressure may be used as really the primary intervention for the compressible bleeding, more as a bridge while preparing another intervention or as part of like wound packing and the pressure bandage application. It can also be directed as self aid if a capable casualty can hold pressure before the rescuers reach them. Now, if bleeding continues despite direct pressure, that's when you're going to escalate based on the wound location. Okay. Severe extremity bleeds may require tourniquet. Deep compressible bleeds may require wound packing. And again, that's going to be with the approved dressing and the specific type of pressure. Now, a pressure dressing specifically is going to be used to maintain just pressure over a bleeding wound after initial control has actually been started. The key word here is going to be maintained. Direct pressure works only while pressure is actually being applied. So, in a tactical care kind of environment, the responder may need to move the casualty, treat another life threat, or just help with more patients. A pressure dressing helps preserve bleeding control when constant hand pressure is no longer practical. Now, a pressure dressing should be applied directly over the bleeding source. If the wound has been packed, the dressing goes over the packed wound. If direct pressure has controlled a surface wound, the dressing should keep pressure over that same point. A wrap placed kind of near the wound or loosely around the limb, it may look complete, but it's not controlling the actual bleed. So you need to wrap firmly and deliberately. The dressing should be tight enough to maintain pressure. Um, and then again, loose wraps are going to slide. Bulky wraps can hide the wound and make reassessment difficult. Overly tight wraps can actually create unnecessary circulation problems. But again, when the bleeding itself did not require a tourniquet. So the goal here is focus pressure, not just random compression. Okay. And also keep the pressure centered over the actual bleed. Again, a common issue is that you're not placing the most pressure over the bleed, is more to the side, and that's going to be detrimental to the patient. Now, if bleeding continues, don't assume that the dressing is successful because it looks good. Just apply more focused pressure and just escalate based on the wound location and your protocol. Now, a tourniquet here is used again for life threatening bleeds from an extremity specifically. That just means the injury is on an arm or a leg, and the bleeding is severe enough that the rapid blood loss could threaten the casualty's life. A tourniquet really is not used for bleeding from the neck, the chest, abdomen, pelvis, or other non extremity locations, right? Those injuries require different basic management and rapid movement to higher care. The most obvious indication is really a severe extremity hemorrhage, right? So, spurting bright red blood, a lot of pooling blood, rapidly soaking clothes or dressing in blood, a mangled limb, traumatic amputations. So, these are not wounds where the responders should just wait for, a late shock before they actually act. Now, a tourniquet is also indicated when direct pressure is not controlling severe extremity bleeds, right? Direct pressure is useful, but if bleeding is still life threatening, the responder should not continue repeating the same ineffective intervention while the patient deteriorates. Now, pressure may also be unsafe, maybe impractical. In a warm zone, rescue operations during casualty movement, multi casualty events, the responder might not be able to just hold pressure for a long time. So that's where the tourniquet come into play. Now, for traumatic amputations, this deserves special attention because even when bleeding appears temporarily reduced, severe bleeds may easily restart. Okay. If the injury involves a total or partial amputation of extremity, the responder should have a really low threshold for tourniquet use. And then also multiple casualties can also affect the decision. When you have several patients needing help, rapid control of severe extremity bleeds allows a responder to move through the scene more effectively. But that does not mean applying tourniquets to minor wounds, right? It means using the correct tool quickly when the injury meets the certain indication. Now, tourniquet placement has really just one purpose, and that's to stop life-threatening bleeding from, an extremity, an arm or a leg. So place the tourniquet above the bleeding site. Again, so it's gonna be proximal, about 2 to 3 inches proximal. Avoid placing it over the knee or elbow, so not over any joints that can prevent, effective compression. When the wound can be exposed, place the tourniquet, again, 2 to 3 inches above. If you can't expose it, then you're really going to use something called high and tight placement on the affected limb. You're going to tighten until the bleeding has stopped. Do not stop because the device looks tight or because the casualty, reports a lot of pain. The pain is expected. Ongoing bleeding means the tourniquet is not tight enough. Okay, so once bleeding has stopped, you want to secure the windlass or the that tightening mechanism. Then mark or report the application time, and then again, reassess that the tourniquet is still being applied appropriately after you actually move the patient. It's also important to note that for the specific tourniquet, uh, you want to tighten it as pretty much as tight as you possibly can go. Uh, if bleeding has stopped and you can actually visibly see the bleeding has stopped, perfect. Otherwise, you can check distal pulses, and if distal pulses are absent, then that's usually a good indication that bleeding has or all blood circulation has stopped in that extremity. Perfect. Tourniquet self application. Now, this matters because a responder or a capable casualty may need to control bleeding before help can actually reach them. So, first, you want to identify the injured extremity, apply the tourniquet high enough on the limb to control the bleed, especially if the exact wound location can't be exposed. Really, the most common failure here is leaving the strap too loose before tightening. You want to remove any slack first, then use the windlass and that tightening mechanism. Tighten until the bleeding has stopped. Secure the device so it does not unwind during movement. And then again, clearly communicate the time and location that it was applied. Like tourniquet, left upper arm, applied at 1425. Now, when applying a tourniquet to another casualty, you really want to work quickly and deliberately. Expose the limb when it's possible so you can identify the bleeding source and avoid placing the device over any bulky clothing or objects. If exposure would delay control of the severe bleed, then you'll use that high and tight placement we talked about. Again, place the tourniquet above the bleeding source, avoid joints, pull the strap as tight as possible, and then tighten until the bleeding has stopped. Once you secure the device, immediately check for the continued bleed. Look at the wound, clothing, and the ground under the casualty. And then again, before movement, make sure the tourniquet remains visible enough so you can reassess. Pretty much at reassess and that the time has been stated and recorded. So if a tourniquet actually fails, right? If it fails, and that life-threatening bleed is going to continue. Don't assume it worked because it's on the limb, right? Continued bleeding means that the device is too loose, poorly positioned, it was mechanically unsecured, or the bleeding source was not, correctly identified. If bleeding continues, you want to tighten the existing tourniquet first if it can still be tightened. A distal pulse with ongoing bleeding is another warning sign, again, that the limb is not fully occluded. If tightening does not stop the bleed, that's when you're going to add a second tourniquet near the first one. And again, for the skill, the correction is tighten or add, never loosen. And as we just talked about, you're going to use that second tourniquet when the first tourniquet does not fully control that severe extremity bleed. Okay. The main trigger here is that bleeding is continuing, right? If the first device cannot tighten anymore, or if the bleeding continues despite the tightening, you're going to apply the second device. You're going to apply the second tourniquet side by side with the first one, about 1 to 2 inches away or proximal. If there's any room, place it slightly above the first, but again, avoid the joints. Tighten the second tourniquet until the bleeding stops, then secure it. And again, after movement, reassess both devices and then again, report the time that they were applied. And that's going to be for both devices. Now, wound packing, this is going to be used for, again, severe bleeds that can be compressed, but is not best controlled with that standard tourniquet. Think of deep wounds where pressure on the surface will not reach the bleeding source. Common examples include, compressible wounds in junctional areas like the groin or the armpit. The bleeding source must be reachable, so if packing can't be placed, if packing cannot place pressure directly into the wound cavity, it's not going to work that great. So you're going to use assigned hemostatic gauze when it's available and appropriate. If the wound is deep, the dressing needs to go into the wound, not across the top. And do not pack open chest wounds or abdominal cavities. Those are going to be managed through different type of injury priorities. Now, again, wound packing is a pressure delivery technique. Okay. So you're going to start with that direct pressure, then pack the gauze into the wound cavity towards the deepest bleeding point. Okay. You want to use firm fingertip pressure and just feed that gauze in layer by layer. The goal is really to fill the empty space so pressure reaches that bleeding source. Once the wound is packed, maintain that direct pressure and really follow the product timing that's taught for the dressing being used. After pressure has been held, secure the wound with a pressure dressing, then reassess for that continued bleeding. And again, always reassess after movement. Now, a hemostatic dressing helps control those severe compressible bleeds, okay? But it still depends on the overall pressure you're applying. So use the dressing really that's identified here in the course. Don't substitute a kind of similar looking product just because it appears to be for bleeding control. You really want to place the dressing inside the wound cavity, not on the surface. Okay. The goal is going to be to have direct contact with the actual bleeding source. Now, after packing, you want to hold firm pressure for a specific amount of time, which we're going to cover more in our lab session. But then you want to secure the wound with a pressure dressing. Okay. Now, once it's applied, you don't remove the dressing. And if bleeding continues, you're just going to add more pressure, reassess the wound, and then at worst case, you'll add a tourniquet. Now, during your handoff, you do want to report what product was used, where the wound is, and then whether the bleeding actually was controlled. Now, moving on to hemorrhagic shock recognition. Now, hemorrhagic shock simply means the body is not circulating enough blood really to maintain organ perfusion. Now, at this level, recognition is really based on patterns, right? Not any lab values that you don't have access to. So, you want to be concerned when major bleeding history is really paired with altered mental status, pale, cool skin, clamminess, diaphoresis, weakness, or weak or absent radial pulses. Now, mental status is going to be one of the key indicators. A casualty who becomes confused, is unusually quiet, agitated, or just unable to follow simple commands, they may be deteriorating, right? So you don't want to wait until they have full blown collapse. Control the bleeding, prevent heat loss, communicate the urgency, and then move the patient towards that higher level of care. Now, hypothermia prevention is part of trauma care. Now, bleeding, shock, again, wet clothing, wind, contact with cold surfaces, that's all going to increase heat loss. So, expose only what you really need to expose that needs to be treated. Okay. Once the life threats are managed, you're going to cover that casualty with your blankets, keep the patient as dry as possible when it's possible. Place insulation between the casualty and the ground, and then cover the torso. Okay. Use the rescue blanket or other dry coverings as soon as it will, as possible, and as pretty much as soon as it won't interfere with those life-saving interventions you're doing. A real simple rule here is just expose to treat and then cover to prevent heat. Okay. Now, airway. So, airway priority. So, airway care really starts with responsiveness and breathing. You need to ask yourself, is the casualty awake? Can they speak? Are they breathing effectively? Do you hear any snoring, gurgling? Do you see poor chest rise and fall? Use manual positioning first, a head tilt chin lift, jaw thrust maneuver, put the patient in recovery position or the position of comfort. All of those are going to be the core elements of assessing and treating the patient's airway. Okay. Um, Clear only visible, reachable obstructions. Don't perform blind finger sweeps. And after any movement, you always want to reassess the airway immediately. Airway positioning can really change during any type of movement of that patient. And again, we're going relatively quick through these skill slides because in the lab is where we're really going to go take a deep dive into these specific interventions. Now, let's kind of go over how to actually open up an airway. Let's start with the head tilt chin lift. Now, this opens the airway really by moving the tongue and the soft tissue away from the back of the throat. Okay, you're going to use this airway positioning when you do not suspect trauma. Okay, but now if you do, you're going to go ahead and do the jaw thrust maneuver, which we'll talk about in a second. But how do you do the head tilt chin lift? You'll simply just place one hand on the forehead and lift the bony part of the chin with the other hand. Okay, you really want to do a good job avoiding pressing into the soft tissue underneath the jaw. And then after opening the airway, you want to reassess whether or not the patient's actually breathing. Okay, is air coming in and out? If there is an obstruction, when you release the maneuver, then you just got to reposition the head again. And then this is where you're going to want to maintain that airway by dropping in an OPA or an MPA. So as I talked about, now let's go into the jaw thrust maneuver. Now the jaw thrust maneuver is primarily used when you want to open up the airway, but you do suspect some type of head or spine trauma. I do recommend if you are dealing with a traumatic situation where the patient is unconscious, always have the assumption that there is some form of head or spine trauma. Okay. The goal really is to move the jaw forward with less neck movement than that head tilt chin lift. You're going to place your fingers behind the angles of the lower jaw and lift the jaw forward. I do recommend placing your thumbs on the zygomatic bones as you move the lower the movable mandible upwards, kind of putting the patient in a pronounced underbite. And again, we're going to show you this in lab and with some of these other videos we're going to show in a little bit. Now, once the jaw is actually lifted, again, reassess breathing and then clear any obstructions that you may see or may hear. Moving on, so before this, we've with the head tilt chin lift and the jaw thrust maneuver, we simply had opened up the airway, but now we really want to maintain the airway, and that's where these airway adjuncts come into play, and they're very, very useful. Okay, at this level, airway care starts with again the manual positioning of the head. Putting the patient maybe in a recovery position or some type of position of comfort. But these airway adjuncts, like the oropharyngeal airway or the nasopharyngeal airway, are considered really only when they are approved by local EMS agencies and within your scope of practice. Now, here in LA County, it does fall within your scope of practice to use an OPA and MPA. So I do recommend having it in your individual first aid kit and utilizing when it's appropriate. Now, this is a very important aspect. Seeing an adjunct in a guideline, again, doesn't mean you can actually use it. Again, California EMSA specifically phrases airway adjuncts as locally approved skills. The basic tactical casualty care reference mentions MPA only if approved. But again, in California, specifically LA County, it's in your scope of practice. Now, it is in the grander national scope of practice, but again, uh, when you start going down the levels, if your medical director says no, they don't want you to do OPAs or MPAs, then it's not, you cannot do it, right? Now, here in the FRO curriculum, you are able to use the MPAs and the OPAs, but again, under local policy. But let's kind of talk about them, right? So, an OPA is an oropharyngeal airway. It's really generally designed for an unconscious patient without an intact gag reflex. Okay, so that means if you try to insert it into their mouth, they're not going to start to gag or almost vomit. Okay, if that does happen, then you'll typically switch to the MPA, which is the nasopharyngeal airway. And then this specific airway adjunct is inserted through the nose and it requires some type of water based lubricant. Now, again, those statements are general EMT airway concepts, but the details of sizing, insertion, the contraindications, and the testing again are going to be something that we're going to cover in lab. Okay. Now the MPA here is it requires that basic or that sorry that water-based lubricant because again, forcing an airway adjunct without that proper lubrication can injure the tissues and make the situation even worse for the patient. Even when an adjunct is approved, it has to be again placed correctly and then of course reassessed. Now, airway adjuncts do not replace positioning. Okay, so a patient with an MPA can still become obstructed. Okay, so a patient with an OPA can still vomit. A patient can deteriorate after movement. A device should never create uh, really false confidence. Okay, now after an adjunct is placed, reassess breathing. Assess chest rise and fall, airway sounds, alter level of consciousness, and see if they're actually tolerating that airway adjunct. You never want to insert an adjunct if you're not trained or authorized. So during a stressful incident, it can be really tempting to do something that you're not really trained to do, but the equipment's right there. But again, just because that equipment is available does not mean you have permission to do it. Okay. Now, In terms of following the protocols and contraindications, airway adjunct decisions can be affected by facial trauma, suspected skull injuries, gag reflexes, the patient's responsiveness, bleeding. So those details are going to be very pertinent when we go into our lab session. So don't worry about it right here, but again, watch the videos on OPAs and MPAs. Moving on to recovery position now. For this is going to be for an individual who is unconscious but is still breathing. And again, you don't suspect a spinal injury. Okay, the purpose here is really to help keep the airway open, allow for blood, vomit, or any type of secretions to pool that are pooling in the mouth to essentially drain out of the mouth. So before rolling the casualty, protect existing interventions like the tourniquets, pressure dressings, wound packing, chest seals, and then after you've positioned them, reassess breathing and reassess all your interventions. You want to continue monitoring while they're in that recovery position. Again, that's going to help maintain the airway. But again, that casualty can still have an obstruction, could vomit, could deteriorate, become hypothermic. So you want to continue reassessing as much as you possibly can. Now, the position of comfort is going to be for a conscious casualty who breathes better in a self selected position. Okay, many patients with breathing difficulties naturally want to sit in a high Fowler's position, maybe lean forward, maybe brace themselves. So, if that position helps breathing and is safe to do so, then you should support that. Okay, don't force a breathing patient flat unless, again, movement or an assessment requires that. You want to monitor respiratory effort, really watch for short phrases, increased work of breathing, fatigue, worsening anxiety, or just overall decreasing in responsiveness. Now, if breathing does worsen, communicate that urgency and then again, prepare for that rapid transport. Now, chest and torso wounds, these are important in this curriculum because, again, breathing problems can develop quickly and they might not really be obvious at first, right? An open or sucking chest wound can allow air to move through a hole in the chest wall. Now, that specifically can interfere with normal breathing mechanics and contribute to trapped air inside of the chest. Now, the first responder's job, again, is not to diagnose an internal injury, right? The job is to recognize the possibility, cover that open defect appropriately, and then reassess breathing and move the patient towards that higher level of care. So, what do you need to do? You want to expose and inspect the area if possible. Remove clothing, jackets, body, or whatever it is. You need to remove everything so the wound isn't hidden from you, right? If conditions do allow, expose enough of the chest just to determine the injury site. Now, at the same time, you want to avoid, again, that unnecessary exposure and protect that patient against heat loss. In BTCC, exposures should be, again, purposeful. Find those life threats, treat them, and then cover the casualty again when it's possible. Treat open and sucking chest wounds. So, how you're going to do that? It's really you need to apply a vented chest seal or a non-vented occlusive seal to cover the defect and secure it in place. Now, the first responder ops review checklist also requires chest and torso wound management, chest seals, occlusive dressing, and to be able to recognize the signs and symptoms of a tension pneumothorax. A vented chest seal is going to be the preferred method. Vented seals are designed to cover the chest wall defect while allowing air or fluid to escape through a little vent mechanism. Okay, the LA County equipment list specifically includes a vented chest seal, and the EMSA's IFAK recommendation states that a vented chest seal is preferred. Now, for certifications, students should know how to apply the stocked chest seal, ensure adhesion, and then again reassess breathing. We also will have you utilize the occlusive dressing. That way, you are prepared for both possibilities. Um, Now, current TECC guidance for first responders really has shifted towards applying that effective vented seal, and if none is available, leaving the wound open. Okay, so that's a good example why, again, local policy matters. For the LA County certification, you need to follow EMSA's guidance and whatever we teach you in the program. But again, if your local policy teaches you an inclusive dressing as the backup, use it like you're trained to do. Okay. Now you want to check for an exit wound also if it's as needed. Penetrating injuries may have more than one wound. So if only the front wound is sealed and an open wound is on the back and it's missed, the patient may continue to have breathing compromise. Inspection should be rapid and appropriate to that environment you're working in. Appropriate to the patient's conditions and the movement needs. Reassess the patient's breathing after you seal it. A chest seal, again, is not the final step. You want to watch for that worsening respiratory distress, increased work of breathing, anxiety, agitation, chest tightness, signs of shock and deterioration. Now, if the patient's condition worsens, again, report it, reassess the seal, and then again, prioritize rapid transport to that higher level of care. During your reporting, again, report the chest wound's location, whether a vented seal or an occlusive dressing was used, whether there was an exit wound, and whether breathing improved or if it worsened after the treatment. Really, it's just important to understand that you need to expose only as needed, seal the open chest wounds with that approved method, check for additional wounds, reassess breathing, and then just have good communication, especially if the patient starts to deteriorate early. Now chest seal application is again we're kind of already covered, but let's kind of dive back into it. It's really used when a casualty has an open wound in the chest or the torso that may allow air to enter into the chest wall. Okay, so expose and inspect, and again that doesn't mean you leave them exposed longer than needed. Now once the wound is identified and treated, protect the casualty from that heat loss. Um, Really, this it's kind of just the exact same information. So we're gonna cover this a whole lot more in the lab in the YouTube videos that we're gonna make on chest seals. So just stay tuned for that because it's I'm just gonna repeat the same information we just kind of talked about. Now attention pneumo. So attention pneumo is a life-threatening chest problem that can develop after a torso trauma. Okay, specifically here we're going to more focus on that sucking chest wound. Now, at the level of a first responder ops of BTCC, your goal is just to recognize the potential of that situation, right? So be alert for penetrating torso injuries, followed by that worsening breathing distress. Okay, watch for increased work of breathing, chest pain, anxiety, agitation, signs of shock. Okay. A key warning pattern here is going to be that worsening distress, respiratory stress after a chest seal has been placed. But really, you just want to use clear language during your reporting after you've applied it, after you apply the chest seal, but more so to let the future providers know that there's a potential or a concern for that tension pneumothorax. Now, when a chest injury patient worsens, okay, it's important to act aggressively, stay focused. First, you need to recognize the change. Was there worsening shortness of breath, increased anxiety, declining mental status? Did their skin signs worsen? Did it worsen after they moved? Reassess the actual chest seal, make sure it's adhered, check whether the edges have lifted. Did it fold on itself? Is there blood blocking the actual adhesion part or just the vent part itself? And consider whether an exit wound or a second wound was actually missed. And again, report what you've seen and report the deterioration of the patient. Now burns, so burns, yeah. So burns and secondary injuries can appear in obviously tactical casualty care incidents, especially when the event involves fire, explosion, chemicals, structural damage, hazmat materials. For the BTCC FRO, burns again are not the main focus here, but the students need enough awareness to recognize urgent problems and really avoid making them worse. Okay, the major priorities are just to stop the burning process, protect the airway, cover the injury, prevent hypothermia, and then move significant burns towards appropriate higher level care. First, you need to stop the actual burning process. Remove the casualty from the heat source when it's safe and within the rescue plan. If clothing is burning, you need to extinguish it. If the burn involves chemicals, contamination, you're just going to follow your local hazmat and decon procedures. Don't rush contaminated patients into the CCP, the ambulance, or the hospital just without considering the responder safety and contamination spread. You want to cover burns with a loose, dry, sterile dressing. The purpose is really just to protect the wound, reduce contamination, and really reduce pain from that air movement across the burn. Avoid those tight circumferential wraps that could become constrictive, especially as the swelling increases. Avoid applying any type of creams, ointments, anything in that BTCC environment. The whole purpose is to keep the care like simple and clean. Also, watch closely for airway burns, facial burns, smoke exposure, thin facial hair, soot around the nose or mouth, a hoarse voice, coughing, stridor, wheezing, increased respiratory distress, altered level of consciousness, or burns in a closed space should all kind of raise concerns for that potential. And again, prevent hypothermia. It's kind of been a common theme throughout, but this is a little bit more specific since we're dealing with an injury to the actual the skin, which really regulates your body's temperature. Because burns can really make heat loss much worse, and trauma patients already lose heat so quickly. It's easy to underestimate because burns feel hot, right, conceptually. But patients with burns can become hypothermic, especially if they're exposed, have wet dressings, they're from those cooling attempts, or they're in just a very cold environment. Again, cover unburned areas using dry coverings and keep the patient off cold surfaces whenever possible. The prioritization should be of significant burns for that higher level of care. And those burns include, the face, hands, feet, genitalia, perineum, major joints, inhalation injuries, things of that nature. Okay. Those might need to be transported to a specialty burn center. Now, before moving a casualty, it's important to protect the interventions that are keeping them alive. Check bleeding control first, confirm the tourniquets are tight, the dressings are secure, those packed wounds are uncompromised and compressed, and there's no major bleeding that has restarted. It's also important to recheck the airway and breathing. Movement of any kind can change airway positions, worsen breathing, or disturb some interventions that are assisting with the patient's breathing. Announce any critical interventions before the move, like if there's a tourniquet on the right leg, a packed wound on the left groin, chest seal to the left chest. And then also cover the casualty when it's ever possible, but keep the critical interventions accessible for reassessment. It's also important to choose the movement method, assign roles, give clear commands, move, and then again, always reassess as soon as is possible. Now, casualty movements is part of patient care. Move only when the route and destination are clear. The team should know where the casualty is going before the move actually begins. Use the fastest, safest method. Speed does matter, but not if the move causes any of your interventions to become disturbed. Okay, you want to match the method to the casualty. Walking, dragging, lifting, carrying, using a litter should really depend on the condition, the personnel you have, the equipment, and the distance that needs to be traveled. Communicate before lifting, before dragging. One person should always take the lead with the count and the direction. And once again, the common theme after any movement, reassess ABCs and just reassess all your interventions. Now we're going to go into the different types of ways that we can move patients. We'll start with drags. So drags are typically used when a casualty has to be moved quickly over a short distance, and a more controlled carry or litter movement is just not immediately practical. A drag may be more appropriate when the casualty is in an unsafe, poorly accessible location, when personnel are limited, when the route is very short, or when speed is necessary to move the casualty towards a more safer point of care. Now, drags are not ideal for every patient, but again, they can be life saving when the alternative is leaving the casualty in a high risk area. A clothing drag uses the patient's clothing near the shoulders or the upper torso to move the casualty. The advantage with this one is just going to be speed, but the limitation is that the clothing can tear, stretch, expose the patient, or just fail to provide enough control. You want to avoid pulling from weak fabrics, belts, equipment straps, or anything that's attached to an injury. Then we have a shoulder drag. So this gives the rescuer more control over the upper body. The primary move, this is really the priority is to move the patient or the casualty rather without pulling on the neck, an injured limb, a tourniquet, a packed wound, or a chest seal where it's going to be impacted. Really the head and the airway should be protected as much as the situation allows. Then we have the one rescuer drag. This may be needed when speed again is going to be the most important aspect, and there's no additional rescuer to help out. It is physically demanding and gives less control, so it should usually be a short distance pull and very purposeful in the movements. A two rescuer drag. This provides the better control again when personnel are available. One rescuer can manage the upper body while the other assists with the lower body. Um, so yeah, so again, but you do need two individuals. Now, use a drag device when it's available and when you're trained with it. Soft litters, transfer tarps, anything that can actually assist with actually moving the patient with a piece of equipment. But really, during any drag, maintain route awareness. Watch for corners, debris, slippery surfaces, stairs, or other casualties. Right. Once the casualty reaches the next point of care, that's when you're going to start reassessing the patient. Now lifts. So lifts are used when the casualty must be raised, repositioned, transferred, moved over an obstacle, right? So compared with a drag, a lift usually gives the team more control, but it also requires more coordination, right? So lifts may be needed to place a casualty onto a litter, move over a curb, a doorway, clear some type of debris on the ground, reposition the patient for treatment, or just transfer to a transport type equipment. Now, before lifting, you need to assign roles. One person should lead the movement. The team should know who controls the head, the torso, who supports the hips and legs, or who's going to watch the route, and who protects the medical interventions. Really clear commands here. It's what's going to prevent injury and prevent confusion. Use short, predictable instructions like lift on three, move to the litter, stop. So very basic, simple, clear text. Everyone should lift, move, and lower all as one unit. Okay. Using proper body mechanics is very important, but again, only if it's possible. You're gonna find yourself in a lot of weird angles, small areas, but whenever possible, use appropriate body mechanics. Now, what does that mean? You want to keep the weight, the load as close as possible to you. Lift with the legs. Avoid any type of twisting motions. And if you need to ask for help, just do it. Because again, the worst thing that can happen is that you injure yourself while you're trying to help somebody else. The rescuer's injury again could reduce the overall response capabilities and just creates another patient. Now, maintain control of the head and torso during these moves, especially when the patient is unconscious, has any type of breathing trouble, or has a chest wound or can vomit. Okay. If someone is assigned to airway control, that person should communicate airway status during the lift. It's very important to avoid disturbing any of your interventions. Now, before lifting, you want to identify those critical interventions out loud so the whole team makes asserted efforts to not grab those areas or compress an area that's already injured. Then, of course, after the lift, we're going to reassess. Now, a lift can shift a dressing, you can loosen up a tourniquet, change the airway position. So again, very important that every intervention is reassessed and along with their ABCs. Carries and litters are going to be used when casualties need more controlled movement than a drag can provide. Carries require adequate personnel. A carry should not be attempted simply because it looks faster, right? If the casualty is too heavy, if the route is difficult, or the critical interventions can't be protected, the team may need more personnel or a different movement device. A chair carry may be appropriate for a conscious casualty who can sit upright but can't walk safely. It may be useful for short movements, hallways, or certain stair type situations. It's not ideal for a casualty, again, who's unconscious, unable to maintain their posture, has active bleeding, severely shortness of breath, or just unstable overall. You have a soft litter, which can be useful for non-ambulatory casualties because it just allows for several rescuers to share the load and just gives it better control, more so than dragging. Soft litters may also move easily through narrow hallways or just crowded areas than your more rigid type of equipment. Um, Good. Now, so the equipment. So again, you have soft litters, transfer tarps, stair chairs, stretchers. Um, all of those can be used, but again, you have to be trained on those pieces of equipment before you can actually use them. The familiarity here matters because, again, equipment that appears simple can be very difficult to operate, especially under stress. So, before longer movements, you do want to secure the casualty, have good communication with your team. Just make sure the patient will not slide or fall, and make sure straps, blankets, handles do not cover or pull on any of your interventions. Again, movements should have a specific destination in mind. In the BTCC FRO, casualties move towards safer care, right? As I talked about, a CCP, cold zone treatment area, transport area, loading area, or just an assigned area outside of that threat kind of situation. Now, special populations, they're going to use the same life saving priorities, but they may need different communication or different movement support. Pediatric casualties may not follow directions, may freeze up on you, or may be separated from caregivers. So, for those kind of patients, you want to use short, calm instructions. For older adults, may have fragile skin, limited mobility, hearing, visual impairments. Maybe they're on certain medications like anticoagulants, or just have a normal cognitive baseline that's kind of confused. Pregnant patients require, again, clear reporting of trauma mechanisms, abdominal pain, bleeding, shock signs, altered mental status, and might need different transport decisions. People with disabilities may depend on wheelchairs, walkers, communication devices, service animals, oxygen, or just another caregiver. Language barriers can look like non-compliance, so you really want to use plain words, gestures, interpreters, bilingual responders, or a caregiver assistance if it's possible. So you need to include all of these factors in your handoff when they affect your care, when they affect your movement, and your transport priority. So an MCI exists when the number of patients, severity of the injuries, or the resource demands just exceed the routine response capacity. Okay, in a BTCC incident, that this can happen relatively quickly. Patients may self-evacuate, some may remain in a hard-to-reach area, and early casualty counts again could be incomplete. So the MCI process organizes the whole response: triage, casualty flow, treatment priorities, transport, patient tracking. All of that's going to be important in this grand scheme. Okay. Use the assigned triage method and report through that incident structure. Now, in LA County, MCI triage uses a modified start and jump start, which we're going to cover in a little bit. Casualty movement should be tracked from the point of injury to the CCP, to the treatment area, and so on. And again, reassess as conditions change, right? Patient categories, transport needs, and overall casualty counts may all change as the incident progresses. So let's talk about the start and jump start triaging method. So these are rapid triage tools really used during mass casualty incidences when responders have to sort multiple patients quickly and use limited resources in the most effective way possible. Now, in Los Angeles County, MCI triage is not something we just kind of make up as we go. We have a reference 519 that really directs provider agencies to implement MCI triage guidelines using the modified start and jump start. Pretty much as necessary. So, for the context of this course, start and jump start are going to be the key triage methods that you're going to learn and understand. Now, SALT is still worth recognizing as a national framework, but again, your local policy determines what is actually used in the field. START is generally used for adults and patients who appear to be young adults, whereas Jumpstart is used for patients who appear to be children. Now, that distinction is very important because children are not just smaller adults. Their respiratory rates, patterns, ability to follow instructions, developmental ability to walk, those are going to be different than adults. Okay. With STAR triage, begin with a global sorting, if you will. Ask anyone who can walk to move to a designated area. Those patients are initially categorized as minor or as a green tag. Right now, that doesn't mean they're ignored forever. It just means they have a lower priority for that immediate hands-on treatment and will need secondary triage later on. Now, for the non walking adult patients, you're going to assess breathing. Okay. If the patient is not breathing, you're going to open up the airway. If they still don't breathe, then they're going to be categorized as deceased or a black tag. Okay. And again, that just depends on your local terminology. Now, if opening the airway causes breathing to resume, then they immediately become an immediate or a red tag. Okay. That's because they require an immediate airway intervention to survive. Now, if the patient is breathing, you're going to count or just estimate the rate. Now, in START triage, a respiratory rate greater than 30 breaths per minute is going to be classified as a red or an immediate tag. Okay. That patient is breathing too fast for the START threshold. And again, they may be compensating for shock, pain, some type of injury, or a serious problem. Now, if the respiratory rate is less than 30, move to perfusion, the circulation. So, depending on, again, your training, perfusion may be assessed by the radial pulse or cap refill. So, if there's no radial pulse or if the capillary refill is greater than 2 seconds, that you're going to categorize that patient as a red tag as well. So, the immediate. Poor perfusion again suggests a circulation problem, and that just can't wait any longer. Now, if breathing and perfusion are adequate, you're going to assess mental status. You just give them a simple command like, hey, open your eyes, squeeze my hand, move your foot. If the patient cannot follow commands, they're going to be a red tag. Okay. If they can follow commands and breathing and perfusion are within the START thresholds, then they're going to be classified as a delayed or yellow. Typically, that means they're totally fine for the most part. They might have some type of injuries, but for whatever reason, they were not able to walk when you told everybody on scene to walk to that designated area, even though the patient can follow commands. Now, for Jumpstart, okay, the Jumpstart follows the same kind of overall idea, but the pediatric breathing pathway is going to be different. Okay. First, ask whether the child can walk. A child who can walk is initially a minor or a green tag, and then they need secondary triage. For our non walking children, you're going to assess that spontaneous breathing. So, if the child is breathing, move to the respiratory rate. If the child is not breathing, you're going to position the airway. Now, if airway positioning causes the child to start breathing, you're going to categorize them as a red tag. If they remain apneic or not breathing, you're going to check for a palpable pulse, typically in the brachial or the carotid artery or femoral. If there's no pulse, categorize the child as deceased or black tag. If there is a pulse but the child is still apneic, give 5 rescue breaths. Okay. If breathing resumes after those breaths, the child's going to be a red tag. Unfortunately, if the child remains apneic after the rescue breaths, they would be classified as a black tag or expectant or deceased. Now, for a child who is breathing spontaneously, you're going to assess the respiratory rate. Now, in Jumpstart, a respiratory rate less than 15 or greater than 45 times per minute will be classified as a red tag. Okay. If the respiratory rate is between 15 and 45, assess the perfusion by checking for a palpable pulse. No palpable pulse means immediate or red tag. Now, if breathing and pulse are adequate, assess the neurological status using your AVPU scale. Alert is appropriate, response to verbal stimuli is appropriate. An appropriate response to painful stimuli may be delayed or that yellow tag. But really, an inappropriate response to pain, posturing, or unresponsiveness, that is what's going to classify them as a red tag. So, Two critical reminders here is first, triage should not delay a rapid life-saving intervention like controlling severe bleed, opening an airway, or positioning a child's airway during jump start. Okay. Second, triage categories can change. A patient can improve after an intervention, they can deteriorate after a movement, or reveal a hidden bleed later on. So reassess after treatment, movement, and if there's any type of condition change. Now, the CCP, okay, the CCP organizes casualty flow. Patients arrive by self evacuation, rescue team movements, drags, carries, litters, or maybe bystander assistance, right? So at the CCP, responders triage, treat, tag, and track. Triage identifies priority, treatment focuses on those life threats, and tagging and tracking just helps maintain that accountability. A CCP may be static or dynamic. It may stay in one location or it may move as routes, threat information, and casualty numbers change. Communicate patient counts and priorities fairly early on, include those immediate, delayed, minor, and deceased, and pediatric counts when it's applicable. The CCP is not the final destination, right? It's just a transition point between rescue, treatment, and the organized movement to transport. Now, triage and treatment commonly happen together, right? A triage tag does not stop bleeding, right? If a casualty has a severe hemorrhage, control the bleeding immediately. Immediate life threats come first, okay? Massive bleeding, airway obstruction, breathing compromise, shock, all hypothermia risk, that comes first. A patient may improve after a life saving intervention, they might deteriorate. That means triage categories, again, are not permanent like we just discussed. Use the triage process simply to organize patients, but keep treatment focused on what really changes survival. Okay. The working rhythm is just sort quickly, treat those immediate life threats, move patients into casualty flow, reassess, and then again update the handoff. Now, transport again connects BTCC field care to that definitive care. Patients should move through an organized kind of transport process, not just random ambulance loading. High acuity patients usually move first. Those are going to be the uncontrolled or recently controlled hemorrhaging, shock, airway compromise, worsening chest injuries, significant burns, pediatric traumas, or just any type of alter level of consciousness. Transport resources should match patient needs when possible. In large incidences, available resources may determine which unit transports which patient. Now, destination communication is very important. The transport team needs patient priority, major injuries, interventions, and the specific destination assignment. Again, continue your reassessment during the transport. Loading and movement can again impact all of your interventions. And lastly, send the patient with that clear handoff and the best really available documentation that you have. Now, the LA County trauma system is the pathway that moves these seriously injured patients from field care to definitive trauma care. BTCC interventions really buy time. A tourniquet, again, can control that extremity bleed. Wound packing can control certain compressible hemorrhages, and so on. Okay. These all just help keep the patient alive long enough to have that patient reach definitive care. So you really want to follow LA County destination policy. Trauma destination decisions are not based on just habit, convenience, memory. They're based on the current EMS agency policy, trauma criteria, pediatric statuses, specialty needs, transport time, MCI coordination, and really at the heart of it, just available resources. Adult and pediatric trauma destination policies also matter. Some trauma centers care for adults only, and some are pediatric specific trauma centers. So, if a pediatric and adult trauma patient are transported together in one aircraft, the receiving trauma center must be both an adult center, trauma center, and a pediatric trauma center. So that's a very specific example of why destination planning can't be improvised. It has to be specific. Use the current trauma center handout, facility names, designations, um, and system directions. All can change, right? Students should not rely on an old class handout, memory from another agencies. It all really comes down to training with your specific agency and being up to date on the current criteria. Now, specifically, LA County trauma triage criteria includes physiologic findings, anatomic injuries, high risk mechanisms, major burns, and there's different special considerations. Now, relevant BTCC examples include hypotension. Abnormal respiratory rates, penetrating injuries to the head, neck, or torsos, mangled extremities, amputations, bleeding, in major pediatric and adult burns. So, really, the system recognizes these time critical EMT transport decisions in these narrow circumstances. An example, an EMT personnel may immediately transport hypotensive patients with life threatening penetrating trauma to the closest trauma center. Okay. And again, reassess during the transport. But it's just you need to provide life saving care, move the casualty in an organized transport, follow the policies, and never let the field treatment delay definitive care when the patient meets trauma criteria. All right, missed reporting. So again, we talked about it a little bit earlier, but again, this is the basic communication structure that's used to transfer these essential patient information. Now, in this curriculum, a casualty may pass through several hands before reaching definitive care, right? So one responder may find the patient, another may control bleeding, another may move the patient to the CCP, the Casualty Collection Point. Another may prepare the patient for transport. Each transfer creates a risk that important information will be lost. Now, MIST reduces that risk by just giving responders a more predictable order for the handoff. Mechanism or medical complaint, injuries or inspection findings, signs or vital signs, and treatment that is rendered. Again, the purpose here is not to give a long story. The purpose is to give the next provider the information they need to continue care. A clear MIST report should answer four questions: what happened? What did you find? How does the patient look now? And what did you do? MIST should be used at every meaningful transfer point. That could include transfer from the initial responder to the rescue team to the CCP to the transport crew, and from the transport crew to the hospital staff. Now, the report may become more complete as the patient moves into a safer area, but really the structure should remain the same. A strong report is just concise, it's organized, it's current. Current matters because patients' conditions are going to change. A patient who was alert when you first found them may be confused, right? Bleeding that was controlled may restart again. Breathing may worsen after the chest wound is sealed. So the handoff should really reflect the patient's condition now, not just the first assessment. A useful misreporting might sound like this, mechanism, penetrating injury during active violence, injury, severe right thigh bleeding, no other major bleeding found on the rapid check. Signs, alert but pale, weak radial pulse. Treatment, tourniquet to the right upper thigh at 1420, bleeding controlled, rescue blanket applied, moved to the CCP. Now, for certification, that standard is not, again, memorizing the acronym. The standard is delivering a report that is complete enough, brief enough, and organized enough for the next provider to act on without guessing. So again, we're going to break it down a little bit more, but kind of just rapid fire. So again, mechanism or complaint just frames the same report, or the same the entire report. Say what happened, or what the main medical problem looks to be. Again, an example: penetrating trauma, blunt trauma, blast exposure, a fall during the evacuation, a burn, etc. Um, Include the approximate time of the injury. If it's known, if it's not known, just write unknown. If it's estimated, make sure you write estimated. Only include operational context when it affects care, right? Smoke exposure, blast exposure, delayed access, limited assessment time before movement. Don't speculate, right? If information is reported but not confirmed, just write reported, okay? If mechanism is unclear, just say unknown. The worst thing you can do is to lie or just provide false information on your reports. Now, injuries or inspection findings, this is going to be what you observe. Lead with the life threats, the severe bleeding, tourniqueted extremity, packed wound, chest wound, airway concern, burn, amputation, alter level of consciousness. Give wound locations: right thigh, left forearm, anterior chest, posterior torso. Again, using appropriate medical terminology and positional terms, directional terms. Now, if you checked for an exit wound, report what you found. If the check was limited, then you got to say that. Include the triage category if it's used. Again, use careful wording, right? Say suspected fracture when it's not confirmed. Say rapid check only when you weren't able to do a full detailed assessment. And then again, update findings after your reassessment, especially if anything changes with the patient. Now, signs and vital signs describe really how the patient looks now, right? Start with mental status: alert, confused, response to voice, pain, or they're unresponsive. Report breathing status: normal, rapid, shallow, noisy, labored. Include pulse and skin signs: weak, rapid, pale skin, cool skin, clammy, diaphoresis, signs of shock. Report blood pressure, oxygen O2 sats if possible. Again, don't lie about your vital signs. And then again, report any type of status changes, right? If the patient became confused, short of breath, weaker, paler, whatever you actually see, just make sure to report it clearly. Really, a good sign statement is like initially alert, now confused after movement, breathing rapid and labored, weak radial pulse, skin pale and cool, blood pressure not obtained. That would be a good, clear, simple write out for this specific missed report. Now, treatment rendered is what was, actually done for the casualty. Start with again time-sensitive interventions: tourniquet, when was it applied, the location, tourniquet right upper thigh at 1420. Report these bleeding control actions: direct pressure, pressure dressing, wound packing, hemostatic agents. If a wound was packed, include the location and whether bleeding was controlled. You want to report airway and breathing interventions. What maneuver did you use? Jaw thrust, head tilt. Did you use an OPA, an MPA? What position did you put him in? Did you use a chest seal? What type of hypothermia prevention did you use? You gave him a blanket. What kind of movement did you do? And then where did you actually take the patient? Everything should be documented, but again, you're not writing a whole story. It's clean, it's simple, it's short, it's to the point. Now, documentation again preserves the patient's story as the care moves forward, right? Capture what matters: major findings, treatments that was performed, any status change, tourniquets, triage categories, movements. Um, the status changes are really going to be important here. If breathing worsened, bleeding restarted, mental status change, intervention failed, you need to document and report it. Okay. Tourniquet time should be recorded. If the exact time is unknown, say it's estimated. Really, documentation should travel with the patient whenever it's possible, whether it's a note, a tag, a verbal report. That stays behind does not help the provider, right? You need to make sure that continuity of care is being established and maintained. So let's kind of do a little scenario, kind of like a verbal exercise. So I'm going to give you a scenario and we'll kind of talk through exactly what to do. We'll do two of these and then we'll kind of move on. Uh, Now, in this scenario, the key priority is the key is priority setting. Okay, so you're assigned to a protected rescue task force. That means you are not freelancing again. You are not entering independently. The team has been formed through the command. Law enforcement protection is part of the assignment, and a route to the casualty collection point has been identified. You're going to encounter two casualties. One has a severe thigh bleed. the other has an open chest wound, right? So both are serious, but the question is not which patient matters more. The question is which immediate threat can kill first, and which intervention can be performed quickly enough to change survival. So, severe extremity bleeding is usually going to be the first intervention priority. If the thigh bleeding is life threatening, apply a tourniquet, tight until bleeding has been controlled, secure the device, and then communicate the time. Really, the full technique has already been covered, and it's going to be covered more later on. So, in the scenario, the important decision is recognizing that uncontrolled massive hemorrhaging cannot wait. Okay. Now, the chest wound also requires rapid care, but if another trained responder is present, the team can work in parallel. One responder controls the bleed while another applies a chest seal. So, but if you are alone or if resources are just limited, control that catastrophic bleed first, then address the chest wound as soon as possible. The chest wound should be managed with, again, the locally approved method with a vented seal preferred when available and appropriate. Now, after sealing, you got to reassess the breathing. If the patient becomes more short of breath, more anxious, more confused, shows signs of shock, that change should be reported immediately. The identified CCP route also matters. Warm zone care is not intended to become, again, prolonged treatment in place. After the life saving interventions are completed or stabilized enough for movement, the casualty needs to move towards the CCP or the cold zone treatment area. Now, before movement, protect the interventions, right? Announce them to the team. Tourniquet on the right thigh, chest seal on the left chest. After movement, reassess both. Did bleeding remain controlled? Did the chest seal remain attached? Did breathing change? Did mental status change? Then prepare the mist. So, a concise report for the bleeding casualty might be mechanism, active violence injury, injury, severe right thigh bleeding, sign, alert, pale, treatment, tourniquet, right upper thigh at 1420, bleeding has been controlled, move to the CCP. Okay. For the chest wound casualty, the report might be mechanism, penetrating torso injury, injury, left anterior chest wound, signs, conscious, labored breathing, treatment, vented chest seal has been applied, no exit wound found on the rapid check, breathing reassessed after movement. Okay. The scenario here tests the whole BTCC mindset, right? The assigned role, rapid life saving priority, movement to safer care, reassessment, and then there's a structured handoff. Let's do one more. So, in this scenario, you're in a cold zone area with four casualties. Okay. One casualty has severe extremity hemorrhaging, one has breathing difficulty, one has a minor wound, one is walking wounded. So, the environment allows more organized action than the warm zone, but resources here are still limited. So, triage and treatment must happen together. The severe extremity hemorrhaging is the first hands on treatment priority. If someone is bleeding to death, the triage label alone does not help them, right? So apply the correct bleeding control intervention, like a tourniquet, and confirm if bleeding has been controlled. Now, at the same time, direct the walking wounded casualty to the designated minor or green area according to, again, your MCI plan. Walking wounded patients still need secondary triage, but again, they should not consume the first hands on resources while immediate life threats are still present. The patient with breathing difficulty needs a rapid assessment, determine whether the casualty is conscious, able to speak, maintaining their own airway, and breathing effectively. Now, if they have an open chest wound, that's where you're going to seal it with the approved method. If they're conscious and breathe better in the upright position, support the position of comfort when it's safe. If they worsen, communicate the urgency and move them into an immediate patient flow. The casualty with a minor wound is not ignored here, but treatment can usually wait until immediate life threats are addressed. Minor bleeding, small lacerations, just stable complaints, again, should not pull attention away from severe hemorrhage or breathing compromise. Now, organized casualty flow, right? Patients really should move towards the CCP, the treatment area, the transport pathway, and again, all dependent on the priority, the triage priority, and local policy. If tags or sequence numbers are used, apply them. If counts are being reported, communicate how many patients are immediate, delayed, minor, or deceased, and again, include the pediatric counts as applicable. Now, reassess really as the scenario evolves, right? The bleeding casualty may need correction if bleeding restarts. The breathing difficulty casualty may worsen. The walking wounded casualty may sit down and become less responsive. And the minor wound may turn out to be more significant after your secondary assessment. Uh, so a useful sequence here is, stop the major bleed, direct the walking wounded, assess the breathing difficulties, sort and tag, move casualties to CCP flow, and then reassess. The goal here is not to do everything for every patient immediately. The goal is to save the most lives by combining rapid life-saving care with organized triage movement. Now, we're going to kind of go over what it's going to be like in lab so you guys can get certified. But really, the lab is where we turn the lecture knowledge here into demonstrated performance. Each skill connects to a core BTCC priority: bleeding control, airway breathing, chest injury movement, reassessment, and the handoff. Okay, for tourniquets, what evaluators are going to be looking for: correct placement, adequate tightening, securement, reassessment, time reporting. For wound packing, the key is packing into the wound, the actual packing into the wound cavity, holding pressure, and securing with a pressure dressing, and then reassessing. For the chest injury, apply the chest seal, check for additional wounds, reassess breathing. For airway, demonstrate manual positioning, recovery position of comfort. And then again, just expect a lot of feedback, correct the skill, repeat it, and then again, make the sequence reliable. Movement and handoff skills are going to combine everything learned so far. A casualty may need a drag, lift, carry, or a transfer device to move from point of injury to the CCP or transport. Before movement, protect critical interventions. Use clear movement commands. One person should lead the count and direction. After movement, reassess. And again, reassess bleeding, airway, breathing problems, chest seals, all your interventions. And then finish with the mist. Again, movement without a handoff, you can lose critical information. So the lab rhythm is going to be very basic. Choose the method, communicate, move, reassess, and then report. Bleeding control competencies, again, is going to begin with recognition. Okay, identify bleeds that can actually kill the patient. Spurting bright red blood, a gross amount of pooling blood, rapidly soaking clothing, an amputation, a mangled extremity, shock signs with suspected bleeding. Choose the right intervention. Direct pressure for those compressible bleeds, tourniquet for those life threatening extremity bleeds, wound pack for the deep compressible bleeds, and pressure dressing to maintain control. If a tourniquet fails, then you need to correct it, tighten it, or add a second tourniquet when it's needed. If packing fails, use the approved dressing or pack the source, hold pressure, reassess. The competency here means that bleeding is actually controlled, not that the equipment was applied. Airway competency, the airway competency. So airway and breathing is going to focus on again the basics, the reliable actions. Recognize when airway support is needed. The unconscious patient, snoring, gurgling, poor chest rise and fall. Breathing changes after movement. Uh, Understands how to use the head tilt chin lift when it's appropriate. How to use the jaw thrust when is it appropriate. Use the recovery position for unconscious breathing patients. Use position of comfort for a conscious patient who breathes better upright and leaning forward, and then so on and so on and so on. The movement competency, again, is just going to be how you're able to accurately demonstrate moving a patient, right? Choose the method based on the casualty, the route that needs to be taken, the available personnel, the equipment, the zone. Use clear commands. Who's going to be the leader? Who lifts? Where the casualty is going? And when to stop. And then, of course, protect interventions. After the movement, you need to reassess. Again, reassess all your interventions. Overall, a good movement skill is just coordinated, it's going to be safe, and it's just clinically aware. Your MIS competency is all about having a clear transfer of care and having good communication. Report the mechanism of the complaint, identify the injuries, your inspection findings, the signs and vital signs, and the treatment that was rendered. Again, this is all about continuity of care, and all we're doing is assessing how is your reporting. Is it clear? Is it concise? Is it simple? And is it quick? Your written competency, again, is going to check whether you apply these BTCC FRO concepts, not just recall the information. You're going to expect questions on terminology, zones, expect role and command questions, know the difference between threat mitigation, rescue ops, medical care. Understand again what kind of treatment you do in direct threat care, indirect threat care. Um, for MCI content, understand modified start and jump start assessments, CCP flows, understand the different components of MIST. Just study really by asking, what is the life threat? What is the correct first action? Where does the casualty go? And what must be reported? It will be a multiple choice exam, um, and it'll be the final step in the certification process. So finally, as we close this lecture, it's important to keep the basic tactical casualty care first responder ops role simple and focused, right? Recognize the immediate life threat, severe bleeding, airway obstruction, breathing compromise, shock, hypothermia risk. These are the problems that drive your early interventions. Stop severe bleeds early. A bleeding control intervention is only successful if bleeding actually stops and stays controlled after movement. Move casualties towards safer care. BTC care is not meant to keep the patient at the point of injury longer than necessary. Reassess continuously. Check after interventions, after movement, when conditions change, and before the handoff. Communication is important. A concise misreport keeps the patient's story moving with the patient. Your lab performance should show the same pattern every single time. Identify, treat, move, reassess, and then finally report. So that completes the lecture portion of the basic tactical casualty care first responder operations. The next step is going to be performance. So in the lab, the goal again is going to be to demonstrate that you can apply the course priority safely, consistently. You will not be evaluated on whether you can repeat every sentence from this lecture. You'll be evaluated on whether you can really recognize immediate life threats, choose the correct approved interventions, perform the skill correctly, reassess the patient, and then communicate clearly. Really expect the skills to connect. A real casualty does not arrive as a single isolated skill station, right? A patient may need a tourniquet, then movement, then reassessment, then hypothermia prevention, then mist. Another patient may need airway positioning, a chest seal, movement to the CCP, urgent reporting for worsening breathing. Okay. The lab here is designed to help you put those pieces together. Use a consistent sequence during practice. Identify the life threat, state the intervention, perform the skill, reassess. Prepare for movement, reassess again after movement, give the mist. That sequence may feel repetitive, but again, repetition is how the process becomes reliable under stress. That's the whole purpose of this whole lecture, the repetition, okay? The repetitiveness. Okay. Feedback is also part of this training. Okay. If an instructor corrects your tourniquet placement, your pressure dressing, wound packing, airway positioning, movement command, structure, apply that correction. Okay. Immediately. Okay. We're not here to judge you. We're here to teach you, and you're here to learn. Okay. Competency is really built through practice. Okay. It's built through feedback, correction, and repetition. Okay. Stay disciplined about your scope. Use the equipment and the skills that are taught in the approved course. Don't add procedures from another course unless they are specifically included in the curriculum and authorized by your local policy. In the BTCC FRO, safe performance matters as much as fast performance. Now, as you move into the lab, keep the central mindset, stop what is killing the casualty. Okay, move them towards safer care. Reassess after every intervention and movement. Communicate what matters and stay within the command, the policy, and the scope. That is the role of the EMT level basic tactical casualty care first responder. Thank you, and I hope you enjoyed.